and the prothrombinase complex via the K1, K2 domains. And the consequence, of course, is that instead of stopping the clot formation, which is desirable, of course, in someone who doesn't bleed, one maintains the clot formation, which is also desirable in someone who does bleed, such as in patients with hemophilia. Next slide, please. If you look at the impact of that, is that ultimately you do form a stable clot, and the clot that is formed, of course, has the potential to have side effects at the end of the day. So I'm going to take you through some of the two molecules at least, but that are currently advanced in the clinical development, that is concizumab and mestacimab. And perhaps to remind you that tissue factor pathway inhibitor occurs in two isoforms, the alpha and the beta format. The alpha is the one that is predominantly in megakaryocytes and platelets, and in fact, it's not the predominant format that circulates in circulation. The beta format is the one that is in the endothelial cells, and is the one that in fact is predominantly the one that is circulating in blood. The important components of the tissue factor pathway inhibitor are the binding sites, or the so-called Kunitz sites. And Kunitz 2 is where, in fact, the concizumab and mestacimab are binding. And it so happens that these two molecules happen to bind to both the alpha as well as the beta isoforms of tissue factor pathway inhibitor. And in the last decade, there's been several molecules that are developed with a view of blocking the tissue factor pathway inhibitor. Started with, of course, with bevacizumab, which was developed to bind to K1 and K2 domains of the tissue factor pathway inhibitor. It is a human IgG2 molecule. Unfortunately, its development was halted because of unacceptable high thrombotic risk associated with it. The next molecule is the MG1113, which is currently in the phase 1 of its development. It is a humanized IgG4 molecule binding to the K2 domain. And in fact, we are looking forward to getting more data on where this development is going to progress. The ones that have quite successfully gone beyond phase 1 and phase 2, and certainly gone into phase 3, are concizumab and mestacimab. Concizumab is a humanized IgG4 molecule, and mestacimab is a human IgG1 molecule. They both bind to the K2 domain, and in fact, they've both completed phase 1 and phase 2 studies, and we do have published data from concizumab, and we are in the process of getting the mestacimab phase 3 data to be published very soon. In fact, I'm going to present some of that data that was presented in an oral format, not yet in generally in the publication format. So I want to start with concizumab, and perhaps the context is important here. Let's first look at the study design. Just to remind you, this was a multi-center study, including 70 sites in 27 countries. It accrued a total of 133 patients, and they included, in fact, in Explorer 7, male patients who were 12 years and older with hemophilia A and B of any severity with inhibitors. And in fact, the patients were either receiving on-demand treatment or what we would call a prophylaxis if they were getting prophylaxis. This is the study design. It's a prospective multi-center open label phase 3 study comprising of 4 groups. The first 2 groups are on-demand treatment patients that were randomized in a 1:2 ratio into arms 1 and 2. And then there's group 3 and group 4. The group 3 are patients who came from Explorer 4, and the inhibitor patients were receiving bypassing agents, were then included in the arm 4. Each of these arms received a loading dose except for arm 1 of concizumab of 1 milligram per kg, followed by a maintenance dose of 0.2 milligrams per kg daily subcutaneously. And of course, they were followed up. Concizumab maintenance dose was continued. And I'll tell you what kind of dosing optimization was undertaken. The bottom line is that these patients at the end of a 24-month period, a week period, they were then put into the extension, which is currently ongoing. So the data I'm presenting, in fact, is an interim analysis before the end of the study. What kind of dosing did the patients get? They got a loading dose of 1 milligram per kg that was given subcutaneously. Then the patients were given 0.2 milligrams per kg on a daily basis. And almost immediately after starting the maintenance dose, at week 4, a pharmacokinetic was done in order to assess the plasma level of concizumab. And that plasma level then informed as to what maintenance dose was required for the patients going forward. If the plasma level was between 200 nanogram per ml and 4,000 nanograms per ml, they continued with a maintenance dose of 0.2 milligrams per kg. If the plasma level was below 200 nanograms per ml, these patients then were increased the dose to 0.25 milligrams per kg, and if the dose was above 4,000 nanograms per ml, the dose was reduced to 0.15 milligrams per kg. And the patients were then followed up for the duration of the primary efficacy period. And I'm going to share with you a summary of the efficacy and the safety results. Let's start with the summary of the efficacy results. What concizumab showed is that there was superiority of those who were on concizumab prophylaxis compared to no prophylaxis. I think this is almost a given, and it's came as no surprise. And in fact, perhaps to nuance that, what I'm going to present here is a cohort only including inhibitor patients. It was a total of 52 patients with hemophilia with inhibitors. You can see from this data in the table that the mean estimated ABR was 1.7 in the concizumab prophylaxis arm compared to arm 1, which was 11.8 in the no prophylaxis arm. You can see there that the ABR ratio was 0.14, and the difference between the concizumab and the no concizumab arms was statistically significant, as shown by the p-value there. And if one looks at the additional data in terms of the median annualized bleed rate, now this is the model-based annualized bleed rate, you can see from arm 1 and arm 2, which is what we're going to focus on here, that there was a median ABR of 0 in arm 2 compared to 9.8 in arm 1. And of course, the question being asked always is, was there a difference between hemophilia A and B? And that is what the next block is showing. The median ABR in those patients with inhibitors who had hemophilia A and hemophilia B phenotype, in fact, was not different from the primary analysis shown in the same table. If one looks at the individual ABRs, what is shown in this graph is the treated spontaneous and traumatic bleeding episodes per individual patient shown as a cross. What is particularly noteworthy here is that if you compare the graph on the left of 19 patients who were not on prophylaxis, there's a wide spread of the ABR compared to the graph on the right, which is the concizumab prophylaxis arm, comprising of 33 patients, very, very narrow spread of the ABR and titer. And of course, one would always ask the question, what was the outcome according to the various treatment episodes? If one looks at the treated spontaneous and traumatic bleeds, the spontaneous bleeding episodes, the joint bleeding episodes, and the target joints, in all of those, the median ABR was 0. And of course, the spread is quite wide compared to arm 1, where it was not 0, and certainly the lowest there was 6.5 and the highest was 9.8, and clearly indicating that overall ABR, irrespective of the type of bleed and the site of bleed, concizumab prophylaxis was actually associated with a significant decrease in bleed rates. And what we've started to measure in all of these therapies now is the proportion of patients with 0 bleeds. In the context of concizumab, there were 64% of the patients receiving concizumab prophylaxis who had 0 bleeds, as shown in this table. In arm 1, out of the 33, 21 did not bleed during the study period. In arm 2, in arm 1, out of the 19 that were included, only 2 did not bleed at all, representing, of course, a 64% proportion of patients with 0 bleeds in the concizumab. Put differently, if one were to interpret this in terms of the odds ratio, patients on concizumab prophylaxis were 23 times more likely to have a 0 treated bleeds when compared to no prophylaxis in this analysis. And then furthermore, the question, of course, you could ask is, was there a difference in inhibitor patients between those who had hemophilia A and hemophilia B? What is shown in this table is the median ABR of the patients in here with hemophilia A and B with inhibitors. You can see that the median is 0 in both of these groups. So there is no difference between the two at all. And perhaps more fascinating, at least from my perspective, is the proportion of patients with target joints which were resolved when they were receiving concizumab prophylaxis. Overall, 92% of the patients with hemophilia A or B with inhibitors, in fact, had target joint resolution. But perhaps in the interest of this particular audience of pediatricians, it is very fulfilling to see that adolescents achieved a 96% target joint resolution, which was slightly higher than in adults, which was 90% target joint resolution. You can see there that, in fact, this is quite impressive, noteworthy, when this study is rolled out into the pediatric population in the near future. I'm going to stop there with regard to the efficacy data and move on to the concizumab safety data and try and summarize the data that was published last year in the NEJM. This is now looking specifically at the patients with inhibitors, 19 in arm A. If you can just go back to the previous slide, please. 19 in arm A and 33 in arm B. You can see in the two slides that the total number of events, in fact, was slightly higher in the arm A patients in the arm B patients compared to the patients who were not receiving prophylaxis. The number of serious adverse events were also slightly higher in the concizumab arm compared to no prophylaxis, both in terms of the number of patients and the number of events. What is particularly exciting, of course, is that one is looking at thromboembolic events. There was only one that was picked up. In fact, the one thromboembolic event that happened led to the pause in the conduct of the study and the institution of mitigating measures. Following the institution of mitigating measures, you can see that there was no thromboembolic event that was observed in the concizumab arm. Injection site reactions are the most common adverse events that one sees with these medications that are given subcutaneously. You can see there that in the concizumab arm, in fact, it was 18.2% of the patients that received that had injection site reactions. Bearing in mind that, in fact, this is cross-sectional. Not everyone is getting 18.2% throughout the study. They come and go as you go along. Particularly exciting is the immunogenicity of concizumab. This was evaluated using a very sensitive ECL assay. The positive anti-drug antibody samples were then subjected to a neutralizing activity assay. You can see there that a total of 33 patients, 26% in fact, had anti-concizumab antibodies, and 8 out of the 33 had an in vitro neutralizing effect. We're saying in vitro neutralizing effect because it did not affect the pharmacokinetic of concizumab, and certainly did not affect the bleeding phenotype of concizumab. Of course, we don't know how to interpret this data and what it means in the context of these patients, but nevertheless, it's an observation that one can see. I'm going to move on to mestacimab, starting with the study design of mestacimab. You can see that it was also a global study conducted in 56 sites in 21 countries, including 127 patients. These patients needed to meet inclusion criteria, which were severe hemophilia or moderately severe hemophilia B with inhibitors or without inhibitors. In fact, the study included 12 to 74-year-olds who were receiving prophylaxis or who were actually on episodic treatment with factor 8 or factor 9. The patients who were on episodic treatment were getting, needed to be included only if they were getting 6 or more bleeds in the previous 6 months. And in fact, if one goes on to look at the study design, eligible patients were then put into an observation phase of 6 months, following which the patients were then put into active treatment phase for the next 12 months after receiving a loading dose of 300 milligrams per kg, followed by a maintenance dose of 150 milligrams subcutaneously given weekly. There was in the protocol a provision that if 150 milligrams every week was insufficient, that the patients in fact could be given double that dose as maintenance of 300 milligrams every week. And of course, all the patients then participated in the long-term extension, which is currently ongoing and is expected to last for at least a period of 16 additional months. And to be interesting to see the long-term data. I will present some of that long-term data here, at least a short version of the long-term data. The data I'm going to present, perhaps to emphasize, it's data on the non-inhibitor cohort. The inhibitor cohort, in fact, will be presented at some stage later. The non-inhibitor cohort is the one that is currently in the public domain, and that is what I'm presenting at the moment. Let's start off with the efficacy data. If one looks at the patients that were exposed to mestacimab, there were a total of 33 of these patients during the observation phase. There were 33, all 33 went on to the active treatment phase, and 29 of the 33, in fact, went on to the long-term extension. The mean ABR, this is the model-based ABR, was 38 in the observation phase, 3.18 in the active treatment phase, and 3.86 in the long-term extension. And if one looks at the difference between the observation phase and the active phase, it's a huge reduction of 92% in the mean annualized bleed rate in these patients. This is all for the treated patients who were on demand. What about the patients who went into the study but were already receiving routine prophylaxis with factor 8 or factor factor 9, one sees a similar pattern of results. A total of 83 patients were included in the observation phase, 79 were in the active phase, and 58 in the long term. And there was a 35% decrease in the mean annualized bleed rate in the patients that were receiving mestasimab compared to the baseline, which is the observation phase. If one looks at the safety results, I want us to focus largely on during the mestasimab in the observation phase as well as the active treatment phase. You can see there that, in fact, there was a slightly higher number of adverse events in the active treatment phase with mestasimab, but the treatment-related adverse events were very few, only 4. If one looks at the serious adverse events, in particular the treatment-related serious adverse events, there were none in the mestasimab arm in this study. And if one looks at the deaths and serious adverse events relating to thrombotic events, there were none in this phase 3 study. And perhaps one could expand on this data and perhaps try to examine the difference between the phase 3 and the phase 2 that we've already published. You'll recall that we published the phase 2 data in 2 back-to-back articles in the British Journal of Hematology last year. And in fact, it was a small number of patients of 26. In that analysis, we did not demonstrate any thrombosis, any allergy, any drug antibodies, any neutralizing antibodies were not seen, in fact. In contrast to that, in this phase 3 study, which had a very large number of patients, 127 in total, there was 1 patient who developed thrombosis. There were 3 patients who developed allergy/anaphylaxis. As I indicated, there were anti-drug antibodies, 8 of which were neutralizing, and in fact, they had no clinical or pharmacologic impact on the patients that one was looking at the time. Perhaps to expand a little bit on the summary of the safety and immunogenicity, there were no thrombotic events that occurred in the phase 3 mestasimab study, as well as in the long-term extension of the 87 patients that have now been followed up for at least 2.5 years. In terms of the injection site reactions and immunogenicity, injection site reactions occurred with a frequency of 10.8%, which is actually in line with other subcutaneously administered therapies. And in 23 out of 112 patients, anti-drug antibodies developed, and in fact, they resolved in the 22 out of the 23 of those participants. As I indicated, they actually had no impact on the bleeding phenotype or the pharmacokinetics of mestasimab. Maybe one could take a pause and try and summarize what are then the advantages of anti-tissue factor pathway inhibitor therapies. And I've tried to be simplistic here. Of course, they are all administered subcutaneously as opposed to the intravenous route of administration of replacement therapy. And we understand that they may offer consistent pharmacokinetics as opposed to the peaks and troughs that one sees in the replacement therapy. They are suitable for inhibitor and non-inhibitor patients, which is unique. And of course, they are suitable as demonstrated by the data from both the mestasimab and concizumab for both hemophilia A and B therapy theoretically, even though I've not presented to you today the whole data set, which will be published soon. What are some of the challenges? There are a number of unmitigated challenges with anti-tissue factor pathway inhibitors. Number one is the pharmacokinetics. They undergo target-mediated drug disposition. The consequence of that, in fact, in the case of concizumab, it has to be dosed on a daily basis because of that target-mediated drug disposition. The monitoring is a particular challenge in the sense that the tissue factor pathway inhibitor that is associated with the endothelial cells is very low in amount. And in fact, it's particularly challenging to be able to measure it accurately. And perhaps more importantly, one does not have predictors of markers or of thrombosis during the use of anti-tissue factor pathway inhibitor that one can use as a handle as to whether the patient was either safe or not safe in using the drug. And then finally, the safety is important. You can tell from the data that I've presented, there's a number of patients that have developed thrombosis, and in particular, there are a number of patients that have developed anti-drug antibodies, even though they have no particular impact on the pharmacokinetics and the bleeding tendency. So if I were to summarize these advances in the care of patients with hemophilia, I hope I've sort of shared with you the unmet needs, in particular, the unmet needs that I've outlined, the intravenous access, the pharmacokinetics of the drug, as well as the immunogenicity. And I've shared with you the phase 3 data on concizumab. And this data indicates that it has high efficacy in bleed prevention. It has an acceptable safety profile in both hemophilia A and B patients. I've also shared with you the preliminary phase 3 data that was presented, in fact, at the WFH Global Forum in Montreal last year. That shows that mestazimab, in fact, has also got a high efficacy in bleed prevention when it is used prophylactically, and it has an acceptable safety profile in inhibitor patients with hemophilia A and B. Taken together, the latest anti-tissue factor pathway inhibitor safety and efficacy data suggests that these molecules may be able to address the current unmet needs that are associated with replacement therapy in patients with hemophilia. With that, I would like to stop and perhaps hand back to Dr. Mahdi, and I'm happy to take questions.
Thank you so much, Professor Mahlango, for the excellent presentation and very impressive data on the emerging therapies, which will make the future of hemophiliacs really much easier and safer as to less bleeding, less joint destruction. Thank you so much, Dr. Mahlango, as I don't see any questions.
Yeah, I can't see any questions in the question and answer facility here.
So thank you so much, Professor Mahlango. So we'll move to the next speaker.
Pleasure.
Our next speaker is Dr. Farrukh Shah. Dr. Shah worked as a consultant hematologist at the Whittington Hospital, NHS, from 2004 through 2021, when she was appointed as medical director for transfusion at NSH Blood and Transplant. She continued to provide clinical services as honorary consultant at Whittington Hospital until 2024. Dr. Shah has joined as a consultant hematologist at Sheikh Khalifa Medical City, Abu Dhabi in April 2024. Dr. Shah has an active research program and is currently involved in the independent safety monitoring committees for the META-BVAT and clinical trials and the Pharmacomozo looking at a new iron chelation therapy. Dr. Shah has published extensively in peer-reviewed journals as part of her research work. She's currently an associate editor for Hemoglobin. And she was awarded the Medal of the British Empire in 2023 for her services to patients living with sickle cell and thalassemia. Welcome, Dr. Farrukh Shah. Dr. Farrukh, can you hear me?
My name is... yes, I can, yes. I don't know if you can hear me. I've sent a pre-recorded talk, so hopefully that should play. Dr. Farooq Shah, and it's my pleasure to talk to you today about groundbreaking treatments for patients with thalassemia. These are my disclosures, and today I'm going to cover drug development over time, gene therapy, specifically talking about the Betty cell and the exa-cel, and then I'm going to present some new data on luspatercept, talk about thalidomide and the results of a meta-analysis, and then talk very quickly about some drugs that are under investigational drug regulatory, iron regulatory pathways, and then talk about the PK activators. So the path to innovative therapies takes a very, very long time. And what you can see here is the innovative therapies that we've actually managed to get over the last 20, 30 years or so. And what you can see is that when, for example, here, the advent of lentiviral vectors started in 1990, but we actually only got approval for lentiviral vector gene therapy strategies in the late in 2020, in essence. So it takes a very long time to go through a cycle of drug development to actually get therapeutics to the market. These are currently clinical trials that are running, either active or completed. Here you can see that the ruxolitinib study has been completed. And then these are studies looking at activin receptor ligand traps, particularly the luspatercept and the sotatercept studies. These studies have by and large completed. And then here you can see the hepcidin agonist or hepcidin mimetic drugs and the ferroportin inhibitors, much of which is actually in very early phase 1, phase 2 clinical trials. And I've just crossed out the mark for the La Jolla study, which was started and then stopped because of failure to show any benefit, but also because of infusion site reactions which were impacting on patients. So I'm now going to talk about gene therapy. You're all very familiar with the gene therapy process. It's an autologous stem cell transplant. A patient is subjected to a screening procedure, stem cells are collected. The stem cells then go for editing, either using CRISPR-Cas9 insertion strategy, or they have a gene insertion strategy such as the Betty cell strategy. Once the stem cells are appropriately modified, they're then sent back to the infusion center ready for infusion. The patient's admitted, given myeloablative chemotherapy, they have the stem cells given back to them, and we then wait for engraftment. And then all the patients that are in any of the gene therapy clinical trials at the moment will go for long-term follow-up monitoring to look at safety and efficacy. So the beta-B globigene automocell or Betty cell data is really data that's been presented at ASH in December of 2023 and December of 2022. And I'm going to talk about the long-term follow-up study, which is the 303 study. And what they have at the moment is 63 patients in the study, and the median follow-up for these patients is about 60 months. What you can see here is that in the phase 1-2 studies, about 68% of patients actually achieved transfusion independence. 14 of these patients sustained transfusion independence over the last 9 years worth of follow-up in some of those patients. One patient no longer meets protocol criteria for transfusion independence because their hemoglobin is below 9 grams per deciliter because of acute health events which are unrelated to the thalassemia, and there's no evidence of any loss of Betty cell treatment effect. On the table here, you can actually see the phase 3 study patients. And what's really important here is that when you look at the phase 3 patients, these patients all got higher stem cell counts and higher viral transduction levels. And you can see really very good hemoglobin levels post-infusion in those patients. And then if you split the patient population based on whether they're beta 0, or non-beta 0, you can see that there is a good response for both populations, but with the beta 0 patients having about a gram less rise in hemoglobin in comparison to the non-beta 0s. If you look at the pediatric setting, the children appear to have a less higher hemoglobin in comparison to the adults. This plot is really interesting and important. It was presented by Dr. Thompson at the American Society of Hematology in December. What you can see here is that patients are split according to their genotype and their age. And what you can see is that most patients have got a pretty good sustained hemoglobin after the infusion. The infusion 24-month period line post 24 months is here. And here at the bottom, you can see the patients who did not receive transfusion independence and the ongoing transfusions for those patients. As you would expect, after becoming transfusion independent, patients' ferritins should come down either through venesection or iron chelation, and that holds true in the study. You can see a reduction, significant reduction in the iron burden as measured by MRI assessment, as well as a significant reduction in the serum ferritin for the patients treated with Beticel. The study basically shows in the long-term follow-up that there has been a significant improvement in patients' quality of life. We would expect this, but we have to remember that quality of life data can sometimes be a bit unreliable in the thalassemia patients because of the chronicity of the nature of their condition and them never knowing what normal actually really is. But the take-home message from here is that there's a significant improvement in the mental component of the SF-36, as well as in the physical component. And if you look at the FACT BMT score, there's a significant improvement in that score as well for all patients in the study. As we know from the Beticel, that the higher the number of transfused cells, the better your response and the more likely you are to have transfusion independence. And this shows from data presented at ASH in 2022 by Mark Walters. We're going to go on to CRISPR-Cas9 gene editing, and I'm presenting some newer data as well as data from EHA from 2022. So as we know, CRISPR-Cas9 gene editing involves the activation of BCL11, which allows increased numbers of hemoglobin F cells to be produced. And what you see here is the fact that there are 2 clinical trials that are being run using exa-cel. The thalassemia trial is THAL111, sickle cell trial is SCD121. And the study basically recruited 45 patients for thalassemia age between the ages of 12 to 35. This is long-term follow-up data in 52 patients with transfusion-dependent thalassemia. And what you can see here is that the majority of the patients are over the age of 18, but there's a considerable proportion of patients who are between the ages of 12 and 18. Median follow-up in this population is about 20.4 months. This is very similar to the plot that I've just shown with the Beticel, and here you can see the transfusion independence for patients, with the 3 patients who did not achieve transfusion independence here in the pink. What's important here is that neutrophil and platelet engraftment occurs on a median of about 29 to 44 days, respectively. So there is some delay in platelet engraftment. 91% of patients actually achieved transfusion independence for a period of 12 months or longer. 3 patients that didn't receive did not become transfusion independent. 1 has had a significant reduction in the annualized transfusion volumes of about 83%, while the other 2 patients have been transfusion-free now for 7.5 months and 4 months, starting 60 days after the last transfusion. For all patients, the total hemoglobin was about 11.4 grams per deciliter at 3 months, rising to above 12 grams per deciliter from month 6 onwards. And the hemoglobin F production is extremely good at 7.7 grams at 3 months, going up to 10 grams per litre from 6 months onwards. There's a pan-cellular distribution of hemoglobin F production across all of the cells. And this is a previous slide, obviously shown at EHA 2022, which shows the pan-cellular distribution of the hemoglobin F. So there is obviously a lot of interest in gene editing for thalassemia, and these are the clinical trials that are currently ongoing. Some of them are in the US, but a lot of these studies are actually being run out of China. What we hope is that as more gene therapy options become available, that the gene therapy treatment will become cheaper and much more widely available for patients. Luspatercept is obviously an activin B receptor ligand trap. It's been around for a considerable number of years, and it inhibits aberrant SMAD2/3 signaling and enhances late-stage erythropoiesis. The BELIEVE study, everyone's very familiar with the layout of the BELIEVE study, so I'm not going to repeat this, but it was a placebo-controlled, double-blind phase 3 clinical trial, which then went on into an open-label extension. In the BELIEVE trial, the results initially looked really quite disappointing in that out of the 224 patients that were randomized to luspatercept, only 21% achieved transfusion independence between week 13 and week 24. That's a fixed time period, and they were considered the luspatercept responders. The long-term follow-up data actually shows really quite interesting data. So if you look at the long-term extension data, and I just want you to focus your mind on the key things that are in the red bar here. If you look at the patients that achieved transfusion response in any 12-week period, not the fixed time window that was originally set up as part of the study, what you can see is that about 70% of patients had a response of a 33% reduction in transfusion burden by any 12-week window, and that increased to 77% of patients after long-term data cuts, so over a prolonged period of time. If you're looking at patients who had a more than 50% reduction in transfusion burden over any 12-week period, it was 40.2%, but that increased to 50% in patients who were in the long-term follow-up. So luspatercept is certainly worth giving a trial.
Yes,
for
that's great.
patients.
Thank you.
Seth
Yes,
and
yeah.
have actually published in the British Journal of Hematology a proforma for how we should approach patients that we're offering luspatercept therapy to. And essentially what they recommend is that at the start of therapy, you do a formal assessment looking at their age, genotype, the transfusion burden, the hemoglobin level, the presence of splenectomy, and the degree of bone marrow suppression. And once you've done that, you should formulate a treatment plan based on the patient's goals and what they wish to achieve as a result of this intervention. You should then initiate therapy using 1 milligram per kilogram and administer that every 3 weeks and assess patients for tolerability and safety. If the patient doesn't have any grade 3 adverse events developing, and there's no evidence of any extramedullary hematopoiesis, then you can continue with that 1 milligram per kilogram response. If they develop extramedullary hemopoietic masses, then it's important to discontinue therapy. And if they've got any grade 3 adverse events, then therapy should be paused, reassessed, and then they can either recontinue or you can discontinue the therapy. With the 1 milligram per kilogram per day response, it's important after the second or third dose to reevaluate the hemoglobin level, the number of units patients being transfused, and the time between transfusions. And at that point, what you can do is either increase the dose to 1.25 milligrams per kilogram per day if there hasn't been a sufficient reduction in the transfusion burden, or you can continue therapy if there has been a sufficient reduction in the transfusion burden. And then again, you reevaluate at specific time points. So essentially, it's worth giving a trial to patients and then making regular evaluations to assess response, and then make a decision about continuation versus stopping at each occasion. The practical aspects around using luspatercept is that it's important to assess pre-transfusion hemoglobin over the 12 weeks prior to initiation, so you know what the mean pre-transfusion hemoglobin is. And a subgroup analysis has indicated that splenectomized patients are more likely to respond to luspatercept, and also patients with a lower transfusion burden have a higher probability of responding. Older patients, these are patients above the age of 32, are also shown to have a higher incidence of response. The Beyond clinical trial I presented last year when I spoke, and the data for this is obviously very familiar to everybody. It is now in clinical use in some countries for patients, and 89 patients completed 48 weeks of treatment, with 39 in the placebo arm. And what you can see is a really clear improvement in patients' hemoglobin levels of the order of around 1 to 1.5 grams for the patients in the clinical trial receiving the therapy. I'm now going to talk a bit about the new investigational drugs that are currently in place. Now, thalidomide, again, last year I presented data on thalidomide. Thalidomide works by inducing hemoglobin F. And a number of studies have shown that its mechanism of action may be that it enhances erythroid transcription factors, particularly GATA1, and possibly inhibits inflammatory factors such as TNF-alpha. This results in an increase in the production of intracellular reactive oxygen species, and increased production of ROS causes ROS-mediated P38 MAP kinase signaling, and histone acetylation, which induces gamma globin gene expression. Interestingly, pomalidomide has recently been shown to be a very potent hemoglobin F inducer with less heterogeneity risk. So this is a meta-analysis of thalidomide as monotherapy. So as you're aware, there are a number of drug trials which compared thalidomide with hydroxyurea, showing a very good response. But with this meta-analysis, they looked specifically at monotherapy, and the inclusion criteria were studies that were conducted prospectively or retrospectively in thalassemia patients. And if 2 or more groups had a comparator, then the group that received thalidomide monotherapy were included in this meta-analysis. Exclusion criteria were combination therapies, such as using hydroxyurea, and patients having treatment for less than 3 months, which wasn't deemed long enough to assess a response. And if patients were of 2 populations of people who were receiving therapy for more than 3 months were included, and case reports and other studies were excluded. So the meta-analysis originally identified 109 studies using thalidomide, but following removal of duplicates and removal of case reports and other inclusion-exclusion criteria, 12 studies were found to be evaluable. And these are the 12 studies that were evaluated. Now, the important thing is that we need to think about what the definitions are. So overall response rate was defined as a greater than 50% reduction in transfusion requirement, or an increase in the hemoglobin level of more than 1 gram per deciliter for patients receiving thalidomide. For non-transfusion dependent patients, overall response rate was defined as a hemoglobin increase of more than 1 gram per deciliter. Complete response rate was defined as a complete cessation of regular transfusion. So if you look at this forest plot here, what you can see is that there's 8 studies which were assessed for overall response rate for thalassemia transfusion-dependent patients. And it was identified there was an 83% response rate in overall response rate in patients with a 95% confidence interval. There was quite a bit of variability in the study as defined by the I-squared. And if you look at the 7 studies that were looking at non-transfusion dependent patients, there was a 91% overall response rate in those patients. And remember, overall response rate is a rise in a hemoglobin of above a gram per deciliter, or a 50% reduction in transfusion requirement. Now, complete response rate is actually completely transfusion independent, and there was 9 studies looking at TDT, and they identified 52% of patients had a complete response rate. One study only reported complete response rate for NTDT for patients. Now, the improvement in hemoglobin is, I think, something that is really quite important. So if you look at the data in the transfusion-dependent patients across 8 studies, this is excluding the study by NAG, which is an outlier study. You can see that the mean change in hemoglobin level from baseline was 1.68 grams per deciliter, with a very good confidence interval. Now, the safety of thalidomide is obviously a major concern for clinicians looking after patients receiving this drug. And 30% of patients did develop some form of an adverse event. 3 patients developed serious adverse events with peripheral neurotoxicity or headache, and 1 patient had a central venous thrombosis, and 1 patient had a seizure, according to the patients in the study population for the meta-analysis. The remaining reported adverse events were mainly mild, and common events included constipation, sleepiness, and a high ALT, and a rash in some patients. Drugs in development include our iron regulatory gene pathway, and these are mainly focused around hepcidin mimetics or hepcidin agonists, such as the TMPRSS6 and the ferroportin inhibitors. These drugs are all in clinical trials at the moment. The La Jolla molecule, obviously, as I mentioned earlier, the trial was halted because of lack of efficacy. The other hepcidin mimetic is the protagonist molecule, and the results of that study are awaited. TMPRSS6 is being investigated by Ionis and Silence Therapeutics, and ferroportin I'm just going to mention very briefly. Ferroportin or vamifeport, the thalassemia studies have been withdrawn because there's no change in the ferritin, but interestingly, studies have been opened in sickle cell disease because vamifeport appears to show a significant reduction in hemolysis and inflammation in the mouse model of sickle, and therefore improves hemodynamics and prevents vascular stasis in the mouse model. So that's now moving to a more rigorous level of investigation. And then finally, I'm going to talk about mitapivat, which is a pyruvate kinase activator. And mitapivat basically works at the final stage of activation and works by increasing the amount of ATP within red cells. Now, increased ATP actually ameliorates ineffective erythropoiesis and iron overload and anemia in mouse model of thalassemia. This is data from the phase 2 clinical study, which was initially presented at EHA in 2021-22. And this data that I'm going to show you is presented last year. So patients in this phase 2 study were randomized to 50 milligrams twice daily, which was then increased to 100 milligrams twice daily. And then they've gone into a long-term follow-up in this study. The primary endpoint is a hemoglobin response, and this was met in 80% of patients with improved markers of hemolysis and erythropoietic activity observed in patients. And the drug's generally really well tolerated in the majority of patients, with some side effects, including initial insomnia, dizziness, and headache. The long-term extension studies are actually extending out to week 72. The hemoglobin has been sustained with improvements in both the erythropoietin, the bilirubin, and the LDH in patients. This is showing the ongoing continued stability of the increase in hemoglobin and the maintenance of hemoglobin. And here you can see that erythroferrone and erythropoietin results have either stabilized or improved. and markers of hemolysis have reduced, i.e. the bilirubin indirect has gone down and erythrocyte reticulocyte ratios have remained good and stable. And markers of iron hemostasis have also improved or remained stable in this population of patients. So in conclusion, along with improvements in hemoglobin concentration, mitapivat has improved markers of ineffective erythropoiesis and hemolysis going out as far as week 72 in alpha and beta non-transfusion dependent patients treated with mitapivat. And this suggests, of course, that this drug can ameliorate complex pathophysiology underlying both alpha and beta thalassemia. And clinical trials are, of course, underway for both alpha and beta thalassemia phase 3 studies. And these are the Rise Up study for sickle cell patients, the Activate Kids T and Activate Kids Plain and Energize for the adult studies. So I just want to say thank you very much for inviting me to give an update on groundbreaking therapies for thalassemia syndromes. I'm very happy to answer questions. Thank you.
Thank you so much, Dr. Shah, for the excellent presentation and very impressive data on the emerging therapies for thalassemia.
Thank you. Thank you. I'm very happy to answer questions.
Apparently no questions, so thank you so much for joining us.
Thank you.
There are one question, Doctor. You can check your question and answer box.
I'm sorry, I can't see the question and answer box. Very happy for someone to read out the question answer, and hopefully I'll be able to answer it.
Okay, there's one question. What would explain the difference in response rates between children and adults to beta cell gene therapy?
Yeah, so that's a really good question. And my view is that I suspect it's related to stem cell collections in children. You're less able to collect optimal stem cells because of weight issues and things like that. And potentially that may explain why the response is not as good, because you've got to have a good enough stem cell count plus a good enough transfection count with the lentiviral vector to actually see the response at the best level. So I suspect that it's because of that, that clearly transplanters and gene therapy people will be better able to give more detail onto that.
Okay, thank you so much, Dr. Shah, for joining us. And now we move to the next speaker, Dr. Lubna Zajdali. Dr. Lubna is a seasoned consultant hematopathologist currently serving at Sultan Qaboos Comprehensive Cancer Care and Research Center in Muscat, Oman. Dr. Lubna earned her fellowship in hematology from Royal College of Pathologists in Australia in 2011, solidifying her expertise in the field. With over 12 years of experience in laboratory diagnostic services, she has spearheaded various initiatives in test implementation, validation, quality assurance, and laboratory management. Dr. Lubna's primary focus lies in hemostasis diagnosis as the chairperson of the National Hemostasis Diagnosis Task Force. She played a pivotal role in establishing Oman's first national laboratory hemostasis diagnosis guideline in 2018, ensuring standardized practices and quality care for patient Her dedication to advancing homeostasis diagnosis extends to her teenager at King Abdulaziz Medical City in Riyadh, Saudi Arabia, from 2019 to 2021, where she oversaw the coagulation laboratory. Welcome, Dr. Lubna.
Assalamu alaikum. Thank you for inviting me to present this talk about inherited pediatric disorder. In my presentation, I will give a brief introduction to inherited pediatric disorder. I will highlight some clinical manifestations and the long-term application related to inherited pediatric disorder. I will focus mainly in the diagnostic approach of inherited pediatric disorder and some current treatment options, with little highlight of the future perspective and I will conclude with that. I will do some abbreviations in this presentation interchangeably, just highlighted here. The inherited pediatric disorders comprise a heterogeneous group of more than 60 rare breathing disorders with abnormal platelet function and or thrombocytopenia, and are caused by genetic mutation that affect the gene responsible for platelet production, structure, or function. Includes signaling cascade, cytoskeletal organization, granule formation, and membrane receptor expression. These mutations can be passed down through families, leading to inheritance of disorders in different patterns, including autosomal dominant, recessive, or extended. Thereby, the inherited pediatric disorders can be classified depending on the defects that appear in the platelet structure. So, if there is the can be classified in defect in platelet receptor, this is associated with defect in platelet receptor, or those of membrane defective membrane phospholipids, or that related to defect in cytoskeleton of the platelet, or those defects in granule secretion, which is commonly used storage for disorder, or defect in signal transduction or negative erythropoiesis. Also, in the enhanced platelet clearance, any defect on that is also another classification. The most commonly known inherited platelet disorders that mainly affect surface components of platelet is glandular thrombocythemia, Bernard-Soulier syndrome, and the platelet type 1 and platelet type 1 disease. Also, the commonly known disorders that mainly affect the intracellular component of platelets is the gray platelet syndrome and the MYH9 disorder. The development in the genetic methodology of detection has been improved dramatically in understanding the platelet pathophysiology with its genetic regulation from each step from the early military forces till the platelet function. The prevalence of inherited platelet disorders, actually the true prevalence is unknown. However, the estimated prevalence is at least 2.7 cases per 100,000. In the recent population genetic study, a large genomic aggregation database shows that it's around 0.329% of subjects in the general population had clinically meaningful loss of function variant in a platelet association gene. This could be close to that of symptomatic one disease, that is about 0.1%. This is an interesting annual global survey has been released in 2022 from the World Federation of Hemophilia, and it is a registry. The number of countries participated around 125, with only 85%, but the number of the identified patients is around 427,000 over the period of 1999 to 2022. Out of these, we have, and most of the common, of course, hemophilia and von Willebrand, but we have the other bleeding disorder, which is about 79,000 cases. The clinical manifestation of inherited platelet disorders is highly variable and can present as a related platelet disorder, or can be part of a variety of other abnormal syndromes. And the clinical complications range from almost negligible to life-threatening and can predispose to development of hematological or malignancy and bone marrow aplasia. And also, it may remain unnoticed for many years, with up to 60% of cases with a proven platelet defect that cannot be assigned to any predescribed inherited disorder. The genotype-phenotype correlation of different types of mutations is still mostly fully defined. And the patient with the IPD can present with easy bruising, frequent nosebleed, heavy menstruation bleed, prolonged bleeding after minor injury or dental procedure or surgery. However, the hemarthrosis or bleeding in the muscle is less frequent in inherited disorder. And it's often can be mistaken for other bleeding disorders such as von Willebrand disease or other coagulation factor deficiency. The diagnostic approach for platelet disorder is very important to start with the clinical history and physical examination. Then we move to laboratory evaluation, genetic testing. In the couple of minutes, I will just focus mainly on this clinical history and the laboratory evaluation. I will focus on the new development and some of the pitfalls that we need to consider when we are when I'm approaching patients with inherited platelet disorder. As we learned from all of us, the clinical history is very important part in checking or deciding which way you go for diagnosis of the patient. What is important in the inherited platelet disorder, in the history, the frequency and severity of bleeding symptoms is very important to be noted. And due to the in the neonates or in the childhood, it's very difficult to get the history related to the bleeding, but specific neonatal bleeding symptoms such as capital hematoma or umbilical cord bleeding or bleeding after immunization or head sampling may be informative in younger children. The timing of onset of hemorrhagic features is very important as well. The trend of using bleeding assessment tools has been suggested by many guidelines to be implemented. The most common used one is the International Society of Thrombosis of Hemostasis bleeding assessment tools score. Although it is very informative and can be a good documentation source, it is not sensitive enough to determine the need for laboratory testing. During taking the history, it's important to exclude acquired platelet dysfunction and the cause of acquired causes thrombocytopenia. Family history is important, consanguinity and historical blood count, which is the assessment of previous reports of CBC, platelet count, and trends of these counts is very important. The history. Clinical examination not only look for evidence of current or recent bleeding signs, you also identify other potential causes of bleeding or related features of recognized syndromes such as hearing loss, heart pace, or bone dysmorphism or mental retardation. So now to the laboratory testing part in our diagnostic approach of inherited platelet disorder. It has been recommended by International Society of Thrombosis and the guideline they published in 2015. And the initial investigation that's used for diagnose inherited platelet disorder and the second line investigation. However, I just modified with the British journal, British guidelines, British Society of Hematology guidelines that has been published recently in 2021. So the initial investigation starts with the simple CBC and mean platelet volume, blood smear morphology, coagulation profile, bone blood screen, and the light transmission aggregometer with granular release by luminoagregometry, flow cytometry. The second line investigation, you can go with extended agonist panel of the light transmission aggregometer and extended panel of flow cytometry. With transmission electron microscope and mixing study to distinguish platelet type from type 2 B1 brand and genetic testing. I will highlight these laboratory tests and highlight the main features of it or main development on it and the limitation in the couple of these, the couple minutes of my presentation. So it is the tested count as known now. It is an automated, and now it's available automated analyzers, and the mean stated volume is also available. Drug parameters which can be reported alongside with stated count. However, local validation of instrument-specific mean stated volume range to use, if we want to use it as diagnostic parameter for inherited disorder, we need the local validation because the variation with the difference is up to 25% between the manufacturer. So if your lab has no local validation of the mean volume, you cannot use it as a diagnostic parameter for inherited disorder. Also, another features has come across in the last few years, the immature platelet fraction or the platelet count that's proven to be a useful marker for thrombolytic activity. The microscopic examination, of course, the assessment of blood film morphology is very important in the diagnosis of inherited disorder. This is a blood film morphology with this blue things in the cytoplasm of the neutrophil, which is doll-like inclusion with somehow large size platelet compared to the red cells. And this is characteristics in MYH9 related disorder. The other morphology is that this is a platelet actually, but it's lacking some the granules in it. So it's look like tail, and this is characteristic feature of the gray platelet syndrome. This is the cone microscope, which shows normal platelets with the normal granulation, but here there is absence of alpha granules, which is a characteristic of the gray platelet syndrome. And here the inclusion of the neutrophils, which is a known characteristics feature in Shinya-Higashi syndrome. The evolutions of a super-resolution light microscopy, which can overcome the resolution limits, improve resolution limits by conventional light microscopy, provide a quantitative high-throughput automated morphometric analysis of thousands of platelets from a single patient. This is an example of these new techniques where they use CD63 as a marker, and this is what how it looks like for normal platelet granules in it. The gold standard investigation for inherited platelet disorder is light transmission aggregometry. Although it has been described in 1960, it's the improvement in the processing and the pre-analytical variabilities took time to be developed over the years. However, there is now international there is a guidelines or consensus expert guidelines published by International Society of Thrombosis and Hemostasis for standardization of the process of the light transmission aggregometry, as well as from North American group for interpretation of the light transmission aggregometer results. And this, of course, increased the accuracy and reproducibility of results and decreased the pre-analytical variabilities of sample preparation. However, the preparation of the platelet-rich plasma that we are using to test this patient and the analysis is time-consuming, and interpretation of the results and correlation with clinical phenotype still need to be undertaken by those with experience. The recommendation, there is recommendation British guidelines advise to use the full panel of agonists for clinical use in the first line investigation, which is beside the 5 agonists, the other new one, which is the thromboxane A2 receptor agonist and the thrombin receptor agonist type. And also, it is important that when you reporting or chasing the the LTA result of the agonist response, that the interpretation should be presented in multidisciplinary team meeting and with the individual experience and the techniques used. And any abnormalities that has been found should be repeated in a fresh sample taken in a separate day to avoid making the confirmation of diagnosis on a single result. The new development in this light transmission agrimetry has been simplified the experimental procedure. The two developments are the first one is the automation of light transmission plated agrimeter application using dedicated software on routine laboratory instruments. Example that's what has been proposed by Sysmic series, the CVC Sysmic series. It's shown repeatability and reproducibility and agreement with the traditional agrimeter. I put the references here for you. There is the second development is that having a high throughput 96 to 384 will-based plated function assay, which has allowed more broader overview of plated function and this time and also reduce plasma volume and can be also good for pediatric age group. The flow cytometry, although requiring relatively expensive equipment and technical expertise, it has been readily available and well established for diagnosis for Glanzmann thrombocytopenia and Bernard-Soulier syndrome. However, extended antibody scan can be performed as a second-line investigation for other inherited disorders. The LUMI agrimeter is a measurement of plated nucleotide. It's mainly used when we have an issue and when we cannot be diagnosed, especially dense granule defect that can be missed by the light transmission agrimeter. However, it fails to address secretion of alpha granules lacking of chromogenic components. The rapid point of care plated function test like the PFA 100, 200, whole blood agrimeter, piezoelastic methods such as Rosen and TEG device is not recommended to be used to screen for inherited disorder as they lack sensitivity for milder disorder. However, they can be of use in monitoring response of treatment after desmopressin, but however in selected cases. Just to point that the quality assurance of laboratory tests for inherited disorders, it has been standardized, except that external quality assurance is not available for the main plated volume and the plated function assay, and that make the test is variable between center to center. The last approach by genetic testing, it is now recommended that genetic analysis should be offered to all patients suspected of having an inherited disorder. And the genetic screening cannot be taken in isolation as the phenotype or function readout of genetic finding is hard to predict. The limitation of genetic testing is lack of accessibility, high cost, and still unresolved ethical concerns on general genetic investigation as variants of unknown significance and unexpected genetic defect can be found. This patient should be informed in advance and comprehend the potential implication of such genetic finding and taking the consent of such is mandatory. I will just go through quickly to a case. We have 2 years old female that has been delivered by cesarean section. No initial medical issue. Lead prep was done with no excessive bleeding, and there was no problem with the fourth separation. However, she experienced bleeding from vaccination site, which lasted 4 to 5 hours, with intermittent epistaxis on and off, usually brought on by crying. That stopped after 5 to 6 minutes. He was admitted to hospital with a gum bleeding that only settled after treatment with tranexamic acid and platelet transfusion. Parent consanguinity, there is third consanguinity, and his brother has no bleeding history. Laboratory results shows normal platelet count with normal morphology, and the live transmission algometry shows clearly no response to all the agonists except for ristocytine. The flow cytometry or the platelet glycoprotein analysis shows complete absence of CD41 glycoprotein 2B and 3A. And genetic testing shows a mutation in homozygous mutation of 856G for C, resulting in this genetic disorder. So this is a straightforward glanzmann thrombocythemia case. However, this is another case that has been presented actually to the adult hematologist with is also female, 28 years old. She has history of heavy menstruation, postpartum bleeding. The childhood bleeding diagnosis was unremarkable. Her CBC shows microscopic hypertonic anemia. Again, the platelet is normal in count and normal size. The blood film morphology was unremarkable. She has normal coagulation profile. The investigation when took place and the factor VIII was normal. The von Willebrand was detected in lower side, the antigen, as well as the cysteine cofactor. The clinician proceeded to go with the von Willebrand multimer, and they found the result came with a mild von Willebrand disease type 1. However, and also the platelet aggregation was done earlier and showed normal aggregation studies, has been reported as normal aggregation studies. When this case came to the discussion in multidisciplinary meeting, the behavior of bleeding of these patients was suggesting more of inherited bleeding disorder rather than coagulation factor deficiency. And the amount of the decrease of von Willebrand, it's not explaining the severity of the bleeding that this patient experienced. So the suggested plan was to repeat the platelet aggregation platelet aggregation, and to go with the gene panel sequencing for platelet inherited platelet disorder. And when it's repeated the platelet aggregation, it shows that there is an absent response in epinephrine with ADP absent secondary aggregation ADP with the presence of primary aggregation. This is not classical for any known inherited platelet disorder so far. However, the gene panel sequence shows a mutation in RAS gene RP2. And this is very rare disorder. So family screening has been done and found siblings and cousins with a similar mutation. However, the bleeding tendency is markedly variable between the sibling and the cousins and the patient herself. So this is an example where the diagnosis can be delayed till adult life, as well as its different expertise when interpreting special coagulation, special platelet function test, as well as the proceed to go with the genetic testing. And it is elicit the importance of multidisciplinary discussion for cases, such cases in the future. For the current treatment option, this is my last objective from this presentation. I'll just go briefly to what is around for treatment of inherited platelet disorder. Of course, we still use drugs that can be used that affect platelet function. Of course, we have to avoid drugs that can affect the platelet function, like non-steroidal anti-inflammatory drugs, and always think about testing and treating iron deficiency anemia of such patients, and to give care of dental hygiene and bleeding identification card can be given to those patients. Local anesthetic treatment like mechanical anesthesia or Fabian C and topical paracetamol acid can be used. Tranexamic acid has been widely used for patients with inherited platelet disorder. Desmopressin as well have poor evidence to support although that has poor evidence to support testing the disproportionate response in patients with an inherited disorder, its selected case can be used and shows effectiveness, but it's ineffective in Glasman thrombocythemia and Rennes-Solier, and it's not recommended in children younger than 3 years, especially if they have also seizure. Other modalities of treatment is transfusion of platelet concentrate. However, the platelet transfusion there should be a weighing of the benefit and risk of platelet transfusion. This is mainly used when there is a high or acute bleeding, and it is used to stop the bleeding. However, the risk of platelet transfusion refractoriness should be weighed with the frequent use of platelet products, and as well of development of platelet antibodies, what is especially reported in Glasman and Rennes-Solier cases, and the transfusion reaction bacteria or viral infection. It's preferable when you use platelet transfusion to give ABO from MASH, HLA MASH product, and to take it from single donor or pooled concentrate. This latest prefer to have leukocyte depleted. This is the recommended cell combination of leukocyte depleted with a short storage duration and tested for any contamination. The other modalities of treatment is recombinant activated factor 7. It has been approved to be used in Glasman thrombocythemia with or without antibodies and with or without refractoriness to platelet transfusion. It's off-label for Rennes-Solier, cerebral disease, and typical bone bond disease, and thrombocytopenia with the absent rodi. That it mainly can be used in acute and controlled for acute and controlled bleeding. Splenectomy is generally not recommended anymore, and allogeneic hematopoietic stem cell transplant can be considered in cases with severe bleeding tendency with the refractoriness and those syndromic inherited platelet disorder, and with Wiskott-Aldrich syndrome, congenital megakaryocytic thrombocytopenia, and Chidiac-Higashi syndrome. Gene therapy so far across the spectrum of inherited platelet disorder, the only approach that has been reached clinical stage of development is the autologous hematopoietic stem cell gene therapy in Wiskott-Aldrich syndrome. We have some data about gene therapy in hemophilia and other coagulation disorder, but inherited platelet disorder, this is the only one so far, and hopefully in the future we'll have more data. So there's some potential future treatment for inherited platelet disorder under investigation, such as artificial platelets, platelet-inspired nanoparticles, biophysical antibodies that bind to the factor 7 and anti-tissue factor pathway inhibitors that have been studied very well for hemophilia case patients. However, it is now considered to be studied also for inherited platelet disorder. So the future direction of management of inherited platelet disorder will focus on decrease the rate of unidentified but suspected platelet defects by elucidating molecular mechanism and expanding genetic screening, and we'll have introduction to the general use of bleeding score or the bleeding assessment score to assess individual bleeding tendency. And we'll have more development escalating for treatment strategy for prevention and treatment of the bleeding episode, and to establish registries to investigate the clinical course of the inherited platelet disorder, with fostering multidisciplinary collaborations and enhancing patient outcome. Also, develop and improve and adapt laboratory tests to monitor treatment, to diagnose and monitor treatment beyond the clinical assessment. So to conclude my presentation, the pathogenesis of congenital platelet disorder is complicated, but has been better understood over the last years. Many advances have been made in understanding the molecular characteristics of these disorders that have helped to have a very accurate understanding of congenital thrombocytopathies and thrombocytopenia. However, we still need the accurate physical examination and history with appropriate laboratory tests to evaluate patients presenting with bleeding diaphysis due to congenital platelet disorder. And the management of inherited platelet disorder often required a multidisciplinary approach involving hematologists, geneticists, and other healthcare professionals. This collaborative approach ensures comprehensive care and the best possible outcomes for patients with these rare and complex disorders. I will invite presentation now with some references. I found it useful to have it when you are looking at this subject in your personal paper. Thank you. This is my end-of presentation.
Thank you so much, Dr. Lubna, for the excellent impressive review of the congenital platelet disorders. And we'll move to the Q&A session. Actually, I don't see any question. Thank you so much, Dr. Lubna.
Thank you.
Our next speaker is Professor Guy Young. He's the director of Hemostasis and Thrombosis Program, attending physician, hematology and oncology, and blood and bone marrow transplant at Children's Hospital, Los Angeles. He is investigator in hematology and oncology, a professor of pediatric at Keck School of Medicine of USC. Following medical school, he completed his residency in Albert Einstein College of Medicine. He then completed a fellowship in pediatric hematology and oncology at Children's National Medical Center in Washington. Welcome, Professor Young.
Hello, this is Guy Young. It's a pleasure for me to be with you virtually. And I am pleased to give this talk to you on emicizumab in hemophilia A in children. Here are my disclosures, including, importantly, I have disclosures with Genentech and Roche and a research grant that I have from Genentech. Obviously, they're the manufacturers of emicizumab. So this is the patient journey, my version of it. And so let's start with the youngest kids, 0 to 3. These are generally the pups. I mean, obviously, some of these patients start some treatment, but I generally call this group the pup group, previously untreated patients. And their main challenges are intracranial hemorrhage and inhibitor risk. The 3 to 12-year-olds, I call these the PTP, or previously treated patients, the young ones. Activity and trauma are their major challenges. Then we have the 13 to 18-year-olds I call PTP teen. Their major challenges are high-risk activities and adherence. And then there are adults, and of course this is a pediatric conference, so we won't be really discussing adults, and they have their own challenges as well. So we'll review the patient journey backwards. And again, I won't discuss adults for this particular talk. Again, you're a pediatric audience. If for some reason you have questions about older adults, some of you might take care of, we can try to handle them during the Q&A session. So I want to start with the teens. As I said, we're going to work our way backwards through the ages. And again, their main challenges are high-risk activity and adherence. What are some of the issues with teenagers? Well, first of all, they have increased independence. So they're often away from their parents. They are beginning to assume responsibility for their own care. So if they have an injury or they need to report that, or they need to do the infusion themselves. They're also often participating in higher risk activities and even for some of them, high-level sports. And we know with teenagers, adherence is a major issue. In terms of high-risk activities, there is really no data so far on emicizumab and its use in high-risk people who are participating in high-risk activities or elite athletes, excuse me. Now, emicizumab, we know, does convert patients to a mild hemophilia phenotype, and my patients with mild hemophilia who are not on prophylaxis, they can and do participate in sports. So it's possible that emicizumab may be protective in this case as well. The fact that there's no data doesn't mean that emicizumab can't be useful for such patients who are participating in such activities or sports, but it's something to keep in mind that we're not sure how well it may protect, for example, a high school soccer player who's playing very intensive level of soccer. So for such patients, the decision to prescribe factor VIII prophylaxis versus emicizumab should be carefully considered. I put here an ice hockey player. It's something we, believe it or not, have a lot of in Southern California, but for you, it could be soccer, it could be basketball. It doesn't matter really what the sport is, but if you let your patients play these sports, and I definitely encourage our patients to play sports, it might be that for some of them, infusing factor before every practice and game, so they have a peak factor VIII level in the normal range, may be a good option, may even be a better option. And emicizumab for these particularly high-level elite athletes may not be the best option. And again, this is a small group of players. I'm not talking about, young children, for example, who play sports. The level of speed and contact and trauma is a lot lower. We're really talking about the teenagers here who are very involved in high-level sports. So what about for high-risk activities? So adding, or some people say topping up with factor VIII for activities. Now, this could make sense if it's not frequent. I do have a patient who likes to ski. Of course, skiing is only done in the winter. He goes a few weekends a year, and he asked, Dr. Young, can I give factor VIII over that weekend to protect myself just in case the emicizumab is not enough, if I have a fall or an injury? Now, of course, he's on a mountain, far from a medical center. All these ski resorts are mostly away from major cities. So I think in this case, it does make sense to give a little bit of additional factor VIII for certain types of activities. So you might think of some examples in your own place. However, it does not make sense if it's an ongoing weekly activity. If you're going to give factor VIII 3 or 4 times a week on top of emicizumab, first of all, it doesn't make any biological sense because they compete with each other. And so as long as the factor VIII level is above about 20%, the emicizumab is not doing anything. It's also very expensive. And so I definitely do not recommend it to give factor VIII regularly and emicizumab. This doesn't make any sense. But to give a few doses, one weekend, another weekend, again, for skiing or other kind of intermittent activities might be something reasonable to do. And then adherence. So we know adherence is a huge problem in teenagers. These are some older papers, but they're really good. I'm going to show you one figure from each paper in a moment. So first, from Dr. Thornburg's paper, this is looking at the percent of patients who keep adherence. And we'll just focus on the circles all the way on the right, 76 to 100%. So these are the patients with high adherence. So you can see in 12 to 23-month-old and 2 to 5-year-olds, adherence tends to be very high. When you get to the school age, only 50% of school age children admit that they have adherence at that high a level of essentially full adherence. And when you get to teenagers, only 20% have really full adherence. And so we know it's a huge problem. And there are other papers that show the same trend. What's the issue with adherence? Well, the biggest issue, if you look here, is the lack of venous access. That's really a major problem or a significant part of the problem for most of the patients, is the lack of venous access. And so perhaps a subcutaneous drug like emicizumab may improve adherence. Now, there's not much data on this yet. This is a poster from a couple of years ago at the ISTH. I think we still need much more data on this, but at least this is a start. So let me show you what they found in this real-world study from one center. So you see here is factor on the left and emicizumab on the right bar. Adherent is greater than 80%. A non-adherent is less than 80%. So 80% of the days covered is what's considered adherence here. So if we look at factor, you can see it's quite all over the place. But you notice that the majority of the patients really do not have good adherence. If we then switch those patients to emicizumab, you can see that you get improvement in adherence So most of these lines are going up. There's actually funny one line that went from 100% down, still adherent for emicizumab, but it did go down. But almost every line is going up, meaning adherence improved with emicizumab. And this makes sense because if venous access and the time it takes to infuse factor can be reduced by having a subcutaneous infusion that can be done much more quickly and easily, it is expected that adherence would improve. But please note, adherence is not perfect with emicizumab either. So let's take a look at a teenager case, breakthrough bleeding. So let's imagine on the left side we have a 14-year-old male with severe hemophilia A and inhibitors. He's been on emicizumab for more than 3 years. He's become more active. He's now playing football, meaning soccer, on a club team. He injured his ankle during a game and he has significant pain. On the other hand, we have a non-inhibitor patient, a 16-year-old male with severe hemophilia without inhibitors. He's been on emicizumab for more than 2 years. He was skateboarding and fell and twisted his knee, and his knee is painful and swollen. So how do we manage breakthrough bleeding? Obviously, this depends on the presence of the inhibitor or not. So what do we know about breakthrough bleed management from the clinical trials, from the Haven trials? First of all, let's take a look at some safety. One thing I think you're all familiar with emicizumab is that there was a number of thrombotic events and thrombotic microangiopathy in the Haven 1 trial, including this one additional one. So we've got 5 events out of about 100 patients, so about 5%. But what was learned is this is when these TMAs and thrombotic events occurred. So this is the duration of APCC treatment. So in other words, these events occurred in conjunction with treating bleeds with APCC. So here's the duration of treatment and here's the cumulative dose. And what you'll notice is that if patients use more than 100 units per kilogram for 24 hours, for more than 24 hours, there were 13 bleeding events treated this way, and 5 of those 13 ended up with a TMA or a thrombotic event. So you can see that that's almost 40% chance of ending up with that situation of thrombosis, thrombotic microangiopathy, if you use more than 100 units per kilogram per 24 hours of APCC for more than 24 hours. You'll notice in the middle column, there were 86 bleeding events treated with 50 to 100 units per kilo per 24 hours, and there was no thrombotic events there. So using APCC with emicizumab is not absolutely not allowed, but you really should not be using high doses for more than 24 hours. And this led to essentially the black box warning that I believe I'll show you momentarily. So what about factor 7A? So this is a complicated figure, but let me walk you through this figure. This is bleeds treated with factor 7A in the Haven trials. So it's the number of bleeding episodes is on the y-axis. The cumulative factor 7A dose per bleed is on the x-axis, and the colors indicate how many doses. So light blue is 1 dose, orange is 2 doses, and so on. Now, forget about the dates. Those dates related to before October 2016 and after, which is when there were some changes made in the protocol. But we can just look at any time because I think this works just fine. So you'll notice here that there are many bleeds, over 30, that were treated with about 90 micrograms per kilogram with just 1 dose, and 1 patient with 6 doses. And here's the other extreme, more than 270 micrograms per kilogram per dose, right? So the cumulative factor 8 dose per bleed. So more than 270 micrograms per kilogram for a bleed. And the dark blue is more than 6 doses. So these patients got very high amounts of factor 7A for quite a long time to treat their bleed. So I'm showing you in the arrows the 2 extremes. The point really is that there were no thrombotic events or TMA with factor 7A, regardless of the dose and the number of doses given. So that means that factor 7A and emicizumab do not seem to have some sort of concomitant drug effect that leads to thrombosis. So here's the black box warning I mentioned. I won't read it to you, but it relates to how much APCC should be avoided. Again, more than 100 units per kilo per 24 hours for more than 24 hours is what led to the thrombotic events. You probably have a similar box warning in whatever country you're working in. I imagine all of them are similarly worded. So what about the non-inhibitor patients? What about patients who are using factor 8 to treat bleed? So here's the safety of factor 8 and an emicizumab co-exposure for bleeding events. So it's a similar table to I showed you with the APCC. Here's the duration of time that the bleeds were treated in 24-hour increments. And here's the factor VIII dose, the average daily dose of factor VIII. There were no thrombotic events. You can see there were 215 bleeds treated. If I go back, you can see lower doses, middle doses, some higher doses for as much as more than 4 days in some cases, and a total of 215, and there were no thrombotic events. So we know factor VIII and emicizumab compete with each other. And so there is no additive or synergistic effect when using factor VIII with emicizumab. And so the way you treat bleeds, breakthrough bleeding, is the same way you do if somebody's on factor VIII prophylaxis. You don't have to alter that at all. So here we go. For inhibitors, avoiding APCC if possible, but you don't have to avoid it entirely. If APCC works for a patient to treat bleeds, then you could use it. Please keep in mind the box warning and do not violate that box warning. You can rely on factor VIIa mostly, even for patients who may have preferred APCC before. Use the lowest doses and the fewest doses necessary. And if factor VIIa fails to stop the bleed, then consider admitting a patient to the hospital for APCC if you've got a serious bleed that you want to do some monitoring. For the non-inhibitor patients, it's easy. As I said, it's the same management as if they're on factor VIII prophylaxis, or even if they're just on demand. You just give factor VIII the same way you would before, not even thinking that the emicizumab is there. And emicizumab and factor VIII compete with each other when factor VIII levels are above 20%. So this is a paper about how to manage emicizumab in hemophilia A patients with factor VIII inhibitors that I put together with some colleagues in the US. I'm not going to go through this algorithm. It's a brief algorithm on management showing that basically try to use factor VIIa. However, if the bleed doesn't stop, call the HTC. Maybe more factor VIIa can be given. But if you're really having trouble controlling the bleed, then admit the patient to the hospital for APCC. This is the algorithm we follow in my institution. Okay, let's take a look at the next age group, the 3 to 12-year-olds that I call PTP young. And their main issues are activity and trauma. We know that particularly 3, 4-year-olds are notoriously getting into trouble with trauma, and even school-age kids often have traumas. The other main issue is that this is the age where we have children with central venous catheters. If they're on factor VIII prophylaxis, we know those have a lot of consequences. It's also the first time kids are away from their parents. These kids are prone to trauma, school activities, playing with friends. The younger ones tend to be clumsy, the 3 and 4-year-old boys. And for parents, convenience and ease of infusions are very important. And so based on all of these issues, which agent might you use for a child of this age? Factor VIII, either standard half-life or extended half-life or emicizumab. So I put together an algorithm here, and I'll walk you through this. The green boxes mean that this is the standard approach. The yellow boxes are a new option, now that we have emicizumab, that could be considered with caution, and the red boxes are the limitations of any of the approaches. So let's say we have a previously treated patient, he's on factor VIII prophylaxis with a standard half-life factor VIII, and he's responding well, he's adherent, he's not bleeding, and if the answer to all that is yes, you can continue the current therapy. If it's working, there isn't any need to change. But the limitation is that continuing with a standard half-life factor VIII, this patient's going to need IV access. They may need a central line. Many kids at this age do need a central line. If they're not using a central line, they can get into the issue of vein fatigue, where it becomes harder and harder to access the veins become scarred. Of course, it takes more time to find veins, even more time to deal with the port, so it's inconvenient. And adherence can be an issue even at this age group as well. Now, if they're not doing to an extended half-life factor VIII, this can be somewhat more convenient, but again, it is still IV. It is still multiple times a week, twice a week, some cases even more than that. And you still need IV access and the same issues I mentioned for standard half-life factor VIII. The other option, and I put it in green because I think it's a standard emicizumab. In fact, the majority of our patients at this age, 3 to 12 years old, who are on prophylaxis are currently on prophylaxis with emicizumab. What are the negatives? Well, we don't have long-term data yet on joint protection. We are not replacing what is missing, which is factor VIII. Emicizumab is not factor VIII, as you know. And there's been questions around bone health, although I'm not personally concerned about that. There are a couple of studies I don't have time to show you that show that bone biomarkers do not change when patients switch to emicizumab, including children. But still, there's some concerns about that in the community. Now, the other option I put in yellow because I don't really think this is a great idea, but if somebody's not responding well with standard half-life factor VIII, or they're not adherent, you could continue the current therapy with a more aggressive regimen, maybe give higher doses, more frequent, or if they're not adherent, you could try to support adherence. But this generally doesn't work, so that's why I put it in a yellow box. So a lot of patients still need central venous catheters, and if adherence is not good, typically it's not going to improve even by trying to continue with the IV therapy. So oftentimes you need to make some sort of change. So if the EHL isn't working or the other approach isn't working, you can always go back to emicizumab, even if you didn't do it initially. So this is the full algorithm. This is published, and I'll show you the paper at the end where you can find this algorithm. So we have a 9-year-old with severe hemophilia who's diagnosed at 9 months of age. His first joint bleed was at 1 year of age, very classic type of presentation. He started prophylaxis, he had a port placed, but after some years, his port stopped working. He had occlusions. We tried to open them with TPA, but it didn't work. Finally, his port could not be used. He rarely bled, but because we didn't use the port, we couldn't use the port anymore. We taught the family venipuncture. At the beginning, it wasn't difficult, but over time, it became more and more difficult to administer his factor. And he started to miss doses, and he started to have joint bleeds. Here's a boy who basically almost never had joint bleeds, and his joints were in great shape. Now he's having joint bleeds because of venous access issues. Again, he's 9 years old. We really didn't want to put a port back in at this age. We switched him to an extended half-life factor 8. This didn't really help very much. The dad sent me this picture. This is actually this patient. You see a bandage, Band-Aid, another bandage. Altogether, there's 6 of them here. And the dad sent me this picture because he said, Dr. Young, this is what I have to do just to get 1 infusion of factor in. So the dad felt very guilty. He's poking his child. This child started having what we call psychological issues due to medical trauma. He became very kind of withdrawn when he needed medical procedures. So it really became a major issue. In October 2018, emicizumab was licensed in the United States for patients without inhibitors. And now he's been on it. It's now October of 2022. We're 4 years later. He has had no bleeding events. His parents are able to administer his his emicizumab. He's actually doing it himself now that he's 13 years old. They're all very happy with the switch. His medical trauma issues and anxiety issues that he had from before have all resolved, and it's really made a huge positive change for his life. Let's take a look at a surgical case. Here's an 8-year-old male. Again, no inhibitors. He had severe dental caries, needed a tooth extraction, and he was on emicizumab for 6 months. Previous to that, he was on factor VIII prophylaxis. So what should we do? Well, we counseled the family about the option to use factor prophylactically or just to rely on emicizumab. And at the end, we decided we'll just manage the dental extraction with no prophylactic factor, relying on emicizumab. We did, of course, prescribe aminocaproic acid as well. So let's take a look at surgeries from emicizumab. This is a paper that will be published soon. I'm just showing the abstract data. There were many surgeries done with the Haven trials. Most of them you can see are minor surgeries, and here are the different minor surgeries. So let's take a look at how these were managed. And again, the investigators weren't told how to manage these, so we each had to make decisions on our own. So first of all, here's a group of patients who were managed without getting any prophylactic coagulation factor. And the first thing you'll notice is that 91% of these did not result in postoperative bleeds that needed any treatment. So not giving any factor before these procedures, again, these are all minor procedures, most of the patients did not have postoperative bleeds that needed treatment. If we focus in on dental, since I showed you a dental case, 42 procedures, 9 treated post-op bleeds. So that's 21% of the dental procedures did require post-op factor if patients didn't get factor before the procedure. Remember that number, 21%. Let's take a look at this other group. This group of patients did get factor before their procedure. You again see most of them, 88% in this case, did not need any factor after they didn't have treated post-op bleeds. Back to the dental, 22 procedures, they did get prophylactic factor, 5 treated post-op bleeds, 23%. Remember, the other number was 21%. So at least what this data is telling us is for dental procedures, whether you give factor before the procedure or not doesn't make a difference. About 20% will need factor after. And it's really not that big a deal. Let's go back to our case. This patient, the procedure went well, but the next day, the father sent me this picture, and he showed me that there was some bleeding. You can see oozing there in the tooth socket. So then we did give him some factor, 1 dose of factor, 50 units per kilo. The next day, he had a nice clot formed. And then the next day, the clot was retracted, or a couple days later, I should say, and eventually this resolved just fine. So again, he didn't get factor before. He did bleed, no big deal. He got a dose of factor after, and there was no significant negative consequences down the line. So finally, let's take a look at our pups. 0 to 3, main issues are intracranial hemorrhage and inhibitor risk. Now, first of all, there are no published pup studies of emicizumab currently. The Haven 7 study is underway, and I believe there will be some data presented at the American Society of Hematology meeting in December. So there are case reports published, and there's this one study, the HOHO-EMI, which was a prospective study, but it only had one pup, so we really can't take much data from that. So I'm going to offer you just generally my comments, questions, opinions, because the pups keep coming. I just got a new pup 2 weeks ago, and I had to make some decisions on this 2-week-old and how I'm going to manage him. So in spite of the fact that we don't have data, we still have to make decisions. Again, there are pup studies underway. I mentioned Haven 7. There are also a couple other US-based pup studies involving emicizumab as well. Now, why would you even use emicizumab in a pup? So here's the first pup I put on emicizumab. 8-day-old male, no family history of hemophilia. He had a circumcision. He bled quite significantly, ended up in our hospital, hemoglobin of 4.7. He got transfused and ultimately was diagnosed with hemophilia A, severe. 5 weeks of age, was fully recovered. Now his parents were really educated. They spent many hours online learning about hemophilia, including social media. And on social media, they interacted with another patient of mine's parents. They made friends with them. That child happened to have an intracranial hemorrhage at 3 months of age. And this is what they said to me. This is now about 3 years ago. They said, Dr. Young, please do everything you possibly can to prevent an intracranial hemorrhage in our son. After all, they heard about another child that did have that. Now, what am I supposed to do? Well, after an extensive discussion, I agreed to start him on emicizumab, but I did tell them the following. There is no data on the use of emicizumab at this age. And remember, he was 5 weeks old. I'm not sure how effective it will be. Of course, I don't have data, so I can't promise that. And I certainly can't promise he won't have an intracranial hemorrhage. And we discussed the issue of delayed inhibitor development, which I'm going to come back to in a few minutes. So, emicizumab in pups, what are the pros? Well, you can start prophylaxis early. It's subcutaneous, right? We never start factor at 5 weeks of age because it's just simply too difficult. If we could start prophylaxis with factor at 2 weeks of age or 5 weeks of age, we would be doing it. We're not doing it because it's just simply too difficult. So can starting prophylaxis early possibly prevent intracranial hemorrhage? Put a question mark there because we don't know. Prevent early joint bleeding? That's possible. I don't think there'd be any harm in using emicizumab in this age beyond the usual risks. We can avoid ports. We don't need a port if we use emicizumab. It's easy and it's relatively convenient, and maybe we can even avoid or at least delay inhibitors. And again, I'll come back to that. Now, the cons are basically, the main con is the lack of data. And in the youngest neonates, factor 9 and 10 levels are lower. And so the question about the efficacy of emicizumab can be questioned. And then this other issue of atypical time of inhibitor formation, which could be delayed, may occur at a dangerous time like trauma or surgery. Again, I'm going to come back to that. First, let's talk about intracranial hemorrhage. How common is it? Well, when it does occur, it happens early in life. You can see this small child with an intracranial hemorrhage. And this is the best data that I found from the UK cohort. And basically, you see here in the blue line, hemophilia A, and you can see the incidence on the y-axis and the time on the x-axis. And you can see here that most intracranial hemorrhage occurs in the first 9 months of life. So this figure tells you that intracranial hemorrhage, when it does occur, occurs mostly before 9 months of age. There is a little bit more between 9 months and about 3 years, but the line is flatter at that point. So I'm going to use this 9-month mark in an algorithm I'll show you soon. Now, with IV factor, as I mentioned, it's really impossible because we can't start prophylaxis in the first few weeks of life. With emicizumab, we certainly can start it. It's not difficult to do subcutaneous infusions in very young children, even the first few weeks of life. So we could at least attempt to prevent intracranial hemorrhage if it's desired. The National Hemophilia Foundation Medical and Scientific Advisory Council has this comment about using emicizumab at this age. It says, I highlighted the portion there, in addition, infants should be considered for prophylaxis with emicizumab at any time after birth, given the increased risk of intracranial hemorrhage prior to initiation of factor VIII prophylaxis. Can emicizumab prevent ICH? Well, there's no proof, and it's going to really be, I think, impossible to prove this with any kind of study. It likely improves the coagulation profile even in neonates, so it certainly can be considered. And I've started a couple of children at 2 weeks of age who did not have an intracranial hemorrhage, but whose family was very concerned about that possibility. So we started them with the intent of preventing intracranial hemorrhage. So let's come back to this other issue, atypical time of inhibitor formation. What do I mean by this? Well, first of all, when do inhibitors form? This is the PEDNET data. I think we all know this, that most inhibitors form by 20 exposure days. By 50 exposure days, the line becomes really fairly flat, and by 75, it's completely flat. So we know that it takes, up to 20 exposure days, even up to 50, before we start to see all the inhibitors that may develop in children. So what is this issue of delayed inhibitor risk? So I've taken some data from this paper, which was really an economic impact model that looked at this issue, and they modeled how long it might take to develop an inhibitor if you're on factor VIII prophylaxis versus emicizumab. So on factor VIII prophylaxis, this group suggested that basically it takes 4 months to see an inhibitor develop, and that makes sense because in 4 months, that's, let's say, 16 weeks, and let's say 2 to 3 times a week dosing, you're going to have 30 to 40 to almost 50 exposure days by 4 months. So you're going to see the inhibitor form. With emicizumab, they estimated that the mean time it would take to see an inhibitor, this is the mean time, is 13.5 years. Because we know patients on emicizumab don't bleed very often. So their factor VIII exposures are going to be very infrequent. And so this is the point I'm trying to make, that if somebody's on emicizumab prophylaxis and they only get factor VIII for a bleed here and there or surgery, they're going to get factor VIII very infrequently. It's going to take a long time to reach 20 exposure days and even longer to reach 50 exposure days. So this is the issue I'm talking about with delayed time to inhibitor development. When I discussed this issue with a couple of patients of mine, it happened to be 9-month-olds. These families chose not to start emicizumab at a very young age. I gave them both the same exact speech about delayed inhibitor development and the uncertainty of when an inhibitor might form. On the left side in orange was a mom who's really concerned about this. She really didn't like thinking about the uncertainty of when an inhibitor might develop. So we chose to start him on factor VIII prophylaxis. The goal was to reach 50 exposure days. We managed to get to 44 exposure days in 5 months using an extended half-life factor VIII. He did not develop an inhibitor. We switched him to emicizumab, which he is still on, and he has what I would think is almost a zero risk of lifelong inhibitors. If he was going to get an inhibitor, he would have got it during that time. On the other hand, in the brown, there was a mom who wasn't concerned about that. She really wasn't interested in IV infusions, didn't want a port, so they just started emicizumab prophylaxis. And this boy has 0 exposure days now at 3 years of age. So he's got an ongoing high risk for developing an inhibitor at some point in his life. So let's take a look at the PUP algorithm, which I split out at 9 months of age based on this intracranial hemorrhage incidence. So if a child's less than 9 months of age, if the family has a really strong desire or concern about intracranial hemorrhage, or if maybe a patient already has an intracranial hemorrhage, you need to start prophylaxis, you can start emicizumab. Now I put this in yellow, again, to be considered with caution. The downside is this issue of delayed or increased inhibitor development. Now, what you can do is once the patient is older than 9 months, whether they're 9 months, a year, or older, you can, in fact, at that point, add factor VIII for either inducing tolerance or what I call inhibitor unmasking. That means adding factor VIII either weekly or every 2 weeks if you want to avoid a port, or even a full dose schedule until 50 exposure days. Now, the weekly every 2 weeks has not really been studied as a tolerizing mechanism, but this is a study that Robert Sidonio is doing called the EMI-PUP study. And it still requires IV access for young children, and some of whom may still need a catheter to get through the 50 exposure days. Now, what if the new pup is not less than 9 months, meaning older than 9 months? The standard approach in green is to start prophylaxis with a factor VIII concentrate. But I already mentioned the IV access issues and the fact that these young children will often, in fact, almost always need a central venous catheter. Once they reach 50 exposure days, well, they're not really a pup, they don't have an inhibitor, you can continue factor VIII still with the IV access issues, or at this point, they're not a pup, you can start emicizumab. It's really the PTP algorithm at this point. Or even if they're older than 9 months, like the example I just gave you before, you could start emicizumab in this patient, even without any factor VIII. But again, you have this issue of delayed or increased inhibitor development. And again, you could, if you want to, add factor VIII at some point to induce tolerance or to unmask the inhibitor. So that is the full PUP algorithm. And again, this one's published as well. Now, unfortunately, the patient you started factor VIII prophylaxis on has developed an inhibitor. Now what do? Should ITI be performed, and if so, how? Let's take a look at some consensus recommendations. First, this is the FIT group I was involved with. So you can see this paper and the details in that paper. Basically, we believe that in this paper that immune tolerance should still be undertaken, and as soon as an inhibitor is detected, we recommend this protocol, which is now called the Atlanta protocol, that's started by Robert Sidonio, 50 units per kilo 3 times a week with emicizumab. So we're using emicizumab to prevent bleeding and this low-dose immune tolerance to basically induce tolerance. If the inhibitor titer rises, you can escalate the dose to the full 200 units per kilo that was used in the immune tolerance study. Then there's a decision point. The patient is responding or not responding, and ultimately you get to a point where either the patient was successful or they failed or they have partial tolerance. The German group also has made some recommendations on this, and they suggest, so they're talking here about prophylaxis after ITI. So if you've been successfully tolerated, what should you do? Ongoing prophylaxis with emicizumab and gradual withdrawal of factor VIII. Ongoing prophylaxis with emicizumab in addition to low frequency factor VIII to maintain tolerance, although there's little evidence on this dosing regimen, or discontinuation of emicizumab prophylaxis and prophylaxis with factor VIII only. Now, I don't think too many families are going to want to discontinue emicizumab and go to factor VIII only. So I think there's another possible approach, which is to discontinue factor VIII therapy after successful ITI and to continue only with emicizumab. But this should be studied. And if we take a look at the inhibitor algorithm, start ITI, yes, if the patient fails, the standard of care now is to start emicizumab or in the future another novel therapy. If there's successful ITI, the standard is to continue factor VIII prophylaxis, but you have the issue of the need for long-term IV therapy. Or I would say, again, in yellow, to be considered with caution, is to start emicizumab. The issue here is what is the risk for inhibitor recurrence? And we don't really know that. Or you could consider not even doing ITI and just using emicizumab, so no ITI at all. But in this case, the downsides, the cautions there, or the limitations, is that you'd never probably be able to use factor VIII for breakthrough bleeding, and you're going to have to rely on lifelong bypassing agents, and we know that's problematic and expensive. There's potentially the risk for worse lifelong morbidity and mortality, and there may not be an option for gene therapy in the future. Now, for the tolerized patient, we have a study called the Priority Study, where we're taking a look at emicizumab versus factor VIII after successful ITI. It's a prospective multi-center randomized clinical trial. It had been funded by Grifols initially, although that funding is no longer ongoing, but we're still continuing with the study. Basically, after successful ITI, patients are randomized to weekly factor VIII plus emicizumab or emicizumab alone, and then they'll be followed for about 2 years, and will determine the rate of inhibitor recurrence. So this is the patient who's on the Priority Study. He was diagnosed at 6 months of age with severe hemophilia. He had a joint bleed in the right elbow. He started factor VIII prophylaxis. He had no inhibitor initially, but then he started getting joint bleeds. An inhibitor was diagnosed with a titer of 23. He started immune tolerance with 50 units per kilo every other day with emicizumab. Initially, his titer went up, but eventually it went down, and he was successfully tolerized. He achieved the tolerance by ISTH criteria. He enrolled in the study. He was randomized to emicizumab alone, and he continued that every 2 weeks. His inhibitor titers did go up a little bit, but they've stayed at a low titer level. And that's at least what's happened with this one patient. So you can't take a lot from this single patient as to what to do after successful immune tolerance. I still think we have a lot of question marks about that. All the algorithms I showed you are published here in this paper that came out last year. And I thank you for listening, and I will happy to take your questions. And that's where I was a year ago on vacation, took that picture in Dubrovnik. Thank you.
Thank you so much, Professor Young, for the very interesting and very informative and impressive presentation. And we move to the next speaker as there is no questions. Our next speaker is The next speaker is Dr. Leonardo Brando. He is a pediatric hematologist, staff of Division of Hematology Oncology at the Hospital for Sick Children since 2004. He is a professor of pediatrics at the University of Toronto, an associate professor of the Dalla Lana School of Public Health, and the thrombosis program director. His main area of academic interest is pediatric thrombosis. He is also involved in global outreach activities for the sick kids, promoting education and improvement of clinical care for children with thrombotic events from resource-limited countries, and co-responsible for the Baxter Sick Kids Hemostasis Thrombosis Fellowship and Takeda Pfizer Latin America Hemostasis Thrombosis Fellowship. Welcome, Professor Brando.
Thank you very much, Dr. Mahdi, and it's a pleasure to participate once again at the International Pediatric Hematology Congress promoted at the Kingdom of Bahrain. I apologize for not being able to be there physically, but hopefully we, in the next 35 to 40 minutes, we can talk a little bit about a theme that, when presents to the clinicians, certainly represents a big challenge. That is on the topic of thrombotic emergencies in pediatric patients. I will be, if I can move to my next slide, these are the conflicts pertaining to this presentation, as some of the work that I'll be presenting that was carried at CKIDS or in Canada was funded by Canadian funding agencies. And obviously I will be talking also about unapproved or off-label use of medications and or devices. So in the next 40 minutes or so, I'll be focusing on basically, the objectives will be twofold, excuse me. First, a brief review of the epidemiology of thrombotic events in children before we zoom in three common, or not common, but rare scenarios that certainly represent thrombotic emergencies with very practical examples, including the vignettes for superior vena cava syndrome, pulmonary embolism, and the more elusive term thrombotic storm. So if I may start with the review of epidemiology of thrombotic events, assuming the audience includes adult pediatric treaters and allied health individuals. So I may be missing, as this is a definition of what thrombotic emergencies consist of. Obviously, vascular occlusions, be it, and venous, arterial, and I won't be talking lymphatic today, or capillary. So vascular occlusions that, if left unrecognized, may lead to irreversible potential loss of organ, limb, or even death. So these are the type of scenarios we are alluding to. And to zoom in, venous thromboembolism that encompasses deep vein thrombosis and pulmonary embolism, I always refer back to the data that was published 30 years ago now, but I want to pay homage to the late Maureen Andrew, Dr. Maureen Andrew. So Dr. Maureen Andrew had her nurse fly out to all 16 Canadian pediatric centers, collecting data manually through chart reviews. And she gathered at that time 137 children aged 0 to 18, portraying the characteristics of those thrombotic events. So treaters would know, because this has been reproduced by all of the other national and local pediatric thrombosis centers, the bimodal distribution with a concentration of individuals with less than 1 year of age and a second peak during adolescent years, primordially either because of unwanted pregnancies or use of contraceptives or conditions during adolescence that start to have their incidence raised that are prothrombotic. Of course, the culprit of all of these events are central venous catheters, but we're talking about emergencies today. This is another graphic way of portraying according to age groups and according to territory, venous on the left and arterial on the right, clinical scenarios that may potentially evolve to thrombotic emergencies according to the definitions we started with. So on the left, on the very left, on the column representing neonatal cases, we have cerebral sinus venous thrombosis. Approximately 45% of all CSVTs, or CVTs if you prefer the abbreviation, occur during the initial 28 days of life. And obviously, if those events are very extensive, they may come accompanied by brain infarction with hemorrhagic conversion. And there are increasingly in the literature, I'm not promoting it because the guidelines are not endorsing it. There are centers considering more aggressive therapy for them. I'll just leave this comment there. Not an open door, inviting you to consider local endovascular thrombolysis for CVTs or CSVTs, but something to be mentioned. Outside of the brain, I've mentioned the board famous, so the classic examination for severe congenital protein C or S deficiencies leading to neonatal purpura fulminans, or bilateral renal vein thrombosis. So renal vein thrombosis being the most common non-catheter neonatal venous thromboembolism complication. And obviously, I'm not mentioning lines unless it leads to tremendously extensive events. And outside of neonatal age group, conditions that are very prothrombotic, such as inflammatory background represented by lupus or inflammatory bowel disorder, where extensive venous occlusions may occur, or severe inherited or anatomic thrombophilia. By anatomic, I mean extrinsic vasocompression that may also ultimately lead to those consequences. Even though we're going to be focusing on venous, and I have one more slide now representing aggressiveness of the venous thromboembolism. So on the very left of the slide, you can have on the bottom lower risk of recurrence and or progression, and on the upper part, higher risk of recurrence and or venous progression. And I have already mentioned that catheter-driven DVT being the bread and butter of pediatric thrombotreaters. Then you may have that second by non-catheter related events, and then you may upgrade it even further to the severe or moderately severe natural anticoagulant inhibitor deficiencies or double heterozygosity status, and then the more elusive, very rare cases that I'll be spending the very last part of the talk on, such as heparin-induced thrombocytopenia, so-called CAPS, catastrophic antiphospholipid syndrome, and thrombotic storm. Before we zooming into the clinical vignettes, a very brief overview on the distribution of arterial events and some of the arterial emergencies, even though we're not going to be talking a whole lot of time spent on them. And this is data coming from, this is single center derived instead of the Canadian, which was multi-center derived registry data from Melbourne, the Royal Children's in Melbourne. And Pulmonago's group would have shown in children almost 100 of them between the ages of 0 and 18, and we can easily identify the lack of the bimodal distribution with concentration of arterial events mostly up to the age of 6 months, primordially on patients with congenital heart defect and catheter-driven events. If we use the same model, focusing now on the right part of the slide on arterial occlusions to the left part of that right side slide, neonates and the other non-neonates are acute ischemic strokes with very low recurrence rate for neonatal stroke or presumed perinatal stroke, and then limb ischemia and aortic occlusion within neonatal age group that, if extensive, may represent emergencies. And on the post-neonatal group, I would bring to your attention post-solid organ transplant arterial occlusions that may take into graft loss. So obviously they are emergencies. And in the older patients, Kawasaki disease, age group around 5-6 years of age, with coronary artery aneurysms as a complication, with occlusion of those leading to myocardial infarction, obviously emergencies as well. Patients that have cardiac or shunt associated with the heart that may occlude, and especially in patients with single ventricle physiology who are very hypercoagulable. And finally, as last examples, I failed to mention endovascular thrombectomy, which is increasing. For some reason, the slides have timer. I apologize for the back and forth. So endovascular thrombectomies, and finally, individuals with Takayasu's arteritis or beta synthase homocystinuria or inherited hyperlipidemia or cholesterolemia, who may eventually evolve with arterial occlusions. And this is the final review using the same triangle or pyramid example of low and high risk of arterial event development and or progression/recurrence. And in the base, and the very young, represented on the left of the histogram that Paul Monago's group generated, the catheter-related arterial thrombotic events with higher risk for patients of the very young, particularly the premature newborns, and patients with multi-lumen or bigger catheter size. Above that, we have patients with inflamed vessel walls in vasculitis or extrinsic compressions, and then you have the stents, and then infective endocarditis with a high potential for embolism, depending on location of the valve that is being affected and the size of the lesion. So that would be a brief overview for both venous and arterial occlusions in the pediatric age group and the ones that can potentially lead to emergencies. Hopefully that first part of the talk, which I spent around 15 minutes or so, will now be seconded by the review of 3 classic vignettes, approximately 10 minutes to each of them. And I'll start by talking a little bit about superior vena cava syndrome, bringing some pictures, and I received okay from the families to share the pictures that are very illustrative. The first, I'll start with this case of a patient I followed together with my pediatric cardiology colleagues, a 6-year-old boy, originally with single ventricle physiology, but a failed Fontan, who ended requiring a heart transplant. It has been 3 years now, and hopefully you can identify or visualize the increased web of superficial venous collaterals he had, because he would have over time, after having 2 central venous catheters placed at different time sets on his upper venous system, both of them with occlusion, would have led to what I'm going to call a subacute onset superior vena cava syndrome, which is different than very acute. I have pictures for that. So he, after post-heart transplant, developed PTLD, so post-transplant lymphoproliferative disorder, but he didn't have increased lymph nodes compressing vessel structures on his mediastinus. He had before the transplant a catheter on his upper venous system that had thrombosed but had fully resolved, and now with his second line, I hope you can. Well, this is the chest, the cardiac operation, but he also had two PICs in the past, and this is how he was presenting with sometimes degree of shortness of breath, and these are the QAG tests he had with increased, not surprisingly, increased D-dimer. The Doppler ultrasound findings showed a partially occluded superior vena cava with one calcified thrombus, showing some chronicity there. And this is the example of him before having the second thromboembolism and after. And I hope you can appreciate the periorbital swelling, and you had seen already the chest picture. So I'm going to show you what I called subacute chronic SVC in contrast to two acute settings. So this was an example in a patient with cardiac condition. This is a second, now neonate, with acute onset, patient with tetralogy of Fallot that post-operatively developed, I hope you can appreciate on the picture on the left, a facial swelling and facial plethora and the richness of increased superficial venous web on his chest, in addition to the swelling that you can hopefully identify. He required high pressure ventilatory support, very high PEEPs because of the increased pressure. And this is after pharmacomechanical thrombolysis carried on a very young patient. And hopefully you can see the immediate impact and the changes that would have occurred. He would have failed or only partially responded to systemic fibrinolytic therapy, and then pharmacomechanical was attempted successfully with the picture post-procedure on the right. And I'm showing now a school age lovely girl with acute lymphoblastic leukemia with a scar of her porocath that ended up being removed. And this is a post-induction that was high-risk leukemia, rich in asparaginase therapy, needless to say what she developed. And you can see this is a picture taken overnight, and you can immediately identify the changes of her phenotype. A systematic review is what I'm going to be basing the discussions on the next 3 or 4 slides. That was published in 2018. Dr. Nasser is now a staff in the West Coast in the US, and he put together on his systematic review 142 pediatric patients that would have been identified with superior vena cava syndrome, divided in 3 main clinical groups. My examples purposely harp on the 2 most common etiologies for SVCs. You can see 31% of those being represented in patients with cancer, and 47% represented by patients with cardiac conditions. The remainder with hematological conditions, but mostly catheter-related. Solid tumors, seconded by lymphomas and mediastinal masses, and by leukemia on the cancer subgroup, and with cardiac, mostly cardiac associated with line associated thrombotic events. In terms of outcomes identified in the systematic review, there were outcomes within acute. Almost half, a bit more than half of the patients would have entertained or developed pleural effusions, plus or minus chylothoraxes. and obviously you lose not only fluid proteins, but you lose antithrombin with chylothorax, which make and ends up making the patient even more hypercoagulable. Morbidity translated mostly by neurologic sequelae, neurologic deficits occurring or identified on patients that survive, obviously, plus or minus hydrocephaly in a third of those, recurrence of the thrombotic event in 1 in 8 patients with a delta time of 5 months, ranging from 1 to 10 years, 1 month to 10 years, with a mortality. That's what the relevant point of the slide that goes into the definition, emergency, with an overall mortality of 18%. Risk factors for increased morbidity or mortality: if the age of the patient, infancy, absence of collaterals identified clinically or radiologically, and the presence of acute complications that are also identified in this slide. The treatment modalities more commonly utilized, obviously because of the acuteness, the elevated degree of acuteness, unfractionated heparin. Second, by the literature would have been changing. Initially, systemic thrombolysis, and in a more contemporary literature, you find more and more endovascular approaches for thrombolytic therapy, and mid to long-term warfarin. Multimodal anticoagulation was the way to go, obviously, with the switches as patients survived, associated with improved outcomes. Now that after this brief review on superior vena cava syndrome, let's switch gears to, another venous occlusion within the pulmonary bed, and I'll go to a second vignette, a patient that I actually saw in the emergency room. She, a female teenager, had just flown from a bit further from Europe after an 11-hour economy flight. Fritz Rosendahl work done 10 years ago, if I'm not mistaken, would have shown long flights defined greater than 4 hours being equivalent to being heterozygous to prothrombin gene mutation in some scenarios. But not only she had that risk factor, she was a user of contraceptives for acne, third generation oral contraceptive, combined oral contraceptive for the last 6 months. Now we know that it's a risk factor, especially in the first year of use. She was obese and, before having the takeaway of her chest CT, and she had asthma, but she comes at the end of the flight with chest pain, goes straight from the airport to the emergency room, and she did have findings suggestive of increased pulmonary pressures with a fixed second sound split and low oxygen saturation in room air, and she was becoming hypotensive, which fits definition for a massive pulmonary embolism, or now high-risk pulmonary embolism. And needless to say, she had filling defect with occlusion of a main pulmonary artery. This work is work that sick kids would have done together with Children's Hospital of Eastern Ontario in Ottawa, CHEO. And together we put a cohort of 170 patients aged from 0 to 18. These are patients exclusively diagnosed with pulmonary embolism. And we can see on the age group distribution that it mirrors that distribution that I would have shown to you on patients with mostly DVTs, and a third to a fourth of them with pulmonary embolism. But interestingly, we have the very similar distribution in terms of age groups. Not only we're showing the similar age distribution, the color coding on each of the bars identifies different pulmonary embolism risk strata. On the darker color, apologies again, on the darker color, you will see the massive pulmonary embolism. So hopefully we can also identify a greater darker blue percentage within each bar on patients with on the younger patients diagnosed with pulmonary embolism, in contrast to the older patients. These here that I'm showing representing the older patients are usually the patients. A greater percentage of these are the ones arriving to emergency rooms that general pediatricians or pediatric emergencies will be more commonly being associated with, whereas the younger group are usually cases identified in hospitalized patients. I would differentiate these two types of pulmonary embolism between what would be called thromboembolic, so close to 70 to 80% of these older patients may have an index deep vein thrombosis as the source for the pulmonary embolism, not necessarily, but yes. Whereas in these instances, they may be facing what is called in situ or in situ pulmonary embolism, where the thrombus occurs within the pulmonary vascular bed. If it was for us to evaluate type of outcomes, and in this publication, we made a composite outcome, which would include death from all causes or from pulmonary embolism alone, pulmonary embolism recurrence or progression, and then pulmonary hypertension. We can see on this Kaplan-Meier curve that if we group the non-massive ones or low risk with the submassive and massive, so higher stratification group, it may be obvious, but it hadn't been shown before, that according to risk stratification, unfavorable outcomes differ with, so at least a 3.5-fold higher with the confidence interval shown in your slide, not too wide, which the wideness reflects precision of the estimate, so between 1.6 and 7.3, statistically significant. Not only risk stratification of pulmonary embolism would be associated with worse unfavorable outcomes, overall mortality and pulmonary embolism exclusively related mortality. So I'll go back. Overall mortality as well as PE-related mortality would differ significantly if it was for one to see a child with non-massive versus submassive and massive. So if unfavorable outcomes, including mortality, differ, it is obviously intuitive that one may need to try to be more aggressive upfront to reverse these outcomes I've just shown before getting to treatment algorithms. We also attempted to evaluate the predictive or discriminatory rather role of tools that would have been used in adults to predict mortality, such as the pulmonary embolism severity index score. So by utilizing a ROC curve analysis model where very good discrimination would come from areas under the curve close equal or greater than 0.9, we can see a limitation of the adult-driven tool with sensitivities of 69%, so moderate at best, and specificity of 81%. So not exactly the results one would be hoping for. Now moving to a less contemporary treatment algorithm and perhaps a more contemporary one that we would have worked together with colleagues at Boston Children. And hopefully I can highlight to you anticoagulation is sine qua non. And then we would evaluate laboratory biomarkers, which would include troponin, for example, and also imaging to quantify right ventricle strain or not, and according to blood pressure, reminding ourselves that we need to relate to age-appropriate blood pressure tables, the presence of hemodynamic decompensation or not. We would then differentiate the patients into low risk, intermediate risk, and high risk pulmonary embolism. And for each of these different gradings, we would consider or not upfront, just exclusive anticoagulation, in contrast to more aggressive regimens, such as systemic versus pharmacomechanical thrombolysis, or eventually even surgical embolectomies. That's a talk in itself, but hopefully I am bringing to you what you can identify. This is an open access algorithm, and happy to share if you send me an email. We will close the review of vignettes by talking about a more elusive hypercoagulable state. Before I get to thrombotic storm in itself, I'm just bringing to your attention case scenarios that are quite rare, but they have commonalities within them. Heparin-induced thrombocytopenia with thrombosis, obviously, is one. Atypical hemolytic uremic syndrome, catastrophic antiphospholipid syndrome, severe congenital protein C deficiency, which has macro and microvascular thrombosis, and very severe cases of infection-associated DIC can also have similar clinical findings, and Trousseau syndrome and eponym. I don't like eponyms because we tend to forget. And the association of, this is in adult or pancreatic cancer associated with thrombophlebitis that is migratory, and then macrothrombosis and HELP syndrome in pregnant ladies. We tend not to see those. Let's talk a little bit, and the family and this patient gave me permission to share his picture. Hopefully you can identify the presence of loss of limb of his left lower extremity and also left upper extremity, all of those because of limb ischemia. He developed, you can't see, tremendous necrosis or ischemia of his chest, a muscular chest, the pectoralis muscle. He developed ischemic colitis. He no longer has a colostomy. He developed line central venous catheter associated upper extremity deep vein thrombosis, testicular infarction. It was a challenge to diagnose this young man who failed regular anticoagulation therapy, but then had schistocytes and ended up having a genetically caused atypical AGUS, treated successfully subsequently with eculizumab, and initially do anticoagulation therapy, and then he remains on nowadays prophylactic DOAC regimen. Thrombotic storm is something I had the pleasure to work with a team of experts gathered at University of Florida, and that team of experts came up with the definitions that you see depicted in this slide, occurring in patients of less than 55 years of age, because it occurs much more commonly has an adult onset. But that group of experts gathered 9 or 10 pediatric cases out of all of the, in comparison to a 2.5 higher fold of adult cases. The definitions, usually unusual vascular location for the occlusion, cases that are refractory to typical anticoagulant response and even atypical or have diminished response to it, thrombotic events that tend to have progressive nature and that tend to grow within the initial week of onset, involving acute arterial or venous occlusion and or thrombotic microangiopathy, hence the term STORM. Thrombosis begets thrombosis, terminologies that are commonly utilized. Very difficult to treat. Prior thromboembolism is not mandatory with a high morbidity and mortality, as you would have seen on the example of the patient I've shown you. Just a table to put all of these unusual conditions in perspective. On the one hand, for CAPS, you may have triggers such as infection or trauma, pregnancy not the case, and obviously antiphospholipid syndrome. Now with the revised EULAR 2023 classification, we need sustained, or well, we need at least once nowadays the antiphospholipid antibodies. In atypical HUS, some of the triggers would include infection that this patient did have, cancer associated, I've already alluded to, hit, of course, the timely onset, 50% thrombocytopenia, so drop 50% from the baseline, and then thrombotic storm, infection or surgery or trauma. The phenotype for thrombotic storm, I already mentioned, arteriovenous and or microvascular. CAPS, sometimes difficult to discern from thrombotic storm, hit venous much more than arterial. And atypical HUS, you can have this potpourri of vaso-obstruction. I've already alluded to the presence of single, dual, triple, or tetra-positive antiphospholipid associated antibodies. For thrombotic storm, there is no specific diagnostic marker. Atypical HUS, obviously decreased ADAMTS13. With cancer, you may have it accompanied by DIC, and excuse me, for the HIT, the classic screening with ELISA, with the PF4 heparin antibodies confirmed by a serotonin release test, for example, or different places have different confirmatory studies, serotonin release being the gold standard, perhaps. And finally, treatment, mainstay anticoagulation for thrombotic storm and catastrophic. HIT, obviously, you need, it's mandatory to have a non-heparinoid, and the atypical HUS, eculizumab plus or minus plasma exchange. Thrombotic storm, you actually throw sometimes single dual anticoagulant therapy and immunomodulatory therapy as well. When we put together the 26 or then 30 plus cases of thrombotic storm that the expert group identifies, submitting them to genetic analysis, this is a schema of one of the genetic signals we ended up identifying associated with the metabolism of chondroitin sulfate. Now, chondroitin sulfate is crucial for the action of thrombomodulin that together with thrombin is the opening for activation of protein C and that ultimately leads to thrombin generation inhibition. Chondroitin sulfate is also important in the synthesis of dermatan sulfate, another natural heparin-like substance we have covering our endothelial cells, or expressed by our endothelial cells, that together with glycocalyx promote an anti-prothrombotic, so an anti-thrombotic phenotypes of our endothelial cells. So that was the signal, genetic signal, that we obtained on our patients. Very interesting, even though we have very scant literature to understand more about it. A final diagnostic approach, if you have patients whose thrombotic phenotype resembles this aggression I've just described, you go after malignancy, and in the absence of malignancy, you check for microangiopathy or lupus anticoagulant antibodies or thrombocytopenia in a timely association with heparin to suggest HIT, and if not, thrombotic storm is the one that remains. So I hope that was, as we reach the 40-minute mark, useful, a very quick review of epidemiology of venous and arterial thrombotic events throughout childhood, highlighting instances where vaso-occlusion may lead to risk of loss of organ, limb, or even life. So there's several instances where this may occur. Venous thrombotic events can obviously be associated with such instances, and prompt recognition and aggressiveness of initial therapy may lead to improved outcomes. Most of what I've shared with you will be present in the 3rd edition of our upcoming publication from our Sick Kids Handbook that will be launched in Bangkok at ISTH, or at least you will have spoilers there. And it was a pleasure to participate. This is where I've been in the last 20 years. And thank you very much. Happy to discuss more during the Q&A session. Thanks.
Thank you very much, Dr. Leonardo, for the excellent presentation and very impressive review of this very important complications or disease in children, which is underdiagnosed and undertreated. So we need to be alert. I mean, by the extensive review you've done, just it's important for all the clinicians to keep an eye and to really keep an eye and consider thrombosis in children to be able to diagnose and then treat them.
Thank you.
Thank you so much, Dr. Leonardo. As there's no questions, so we come to the end of day 1 of the conference. I would like to thank so much all the eminent speakers for joining us today and sharing their experience with us. Thank you so much to the attendee. Have a good time. Tomorrow we'll start at 9 a.m. So kindly log in 15 minutes earlier, and inshallah see you all tomorrow. Good night.
Thank you. Good evening. Thank you, Dr. Mahdi.
Bye, Dr. Leonardo.
Bye. Thank you.
Bye.
Will you be in Bangkok?
Sorry?
Do you think you will be attending ISTH in Bangkok?
No, unfortunately not. No.
Okay. So thank you. Are you planning on having the conference again next year?
Inshallah, yes.
Yes. Okay. So I'll see you next year then. Thank you.
Next May, inshallah.
Thank you. Bye-bye.
Next May. Excellent. We're really honored to have you with us.